Oh, I can't get down there. I'll do this without. Okay. Good morning. Oops. Oh, boy. All right, guys, hold on. Okay. All right. Are you guys getting my emails? Is anybody not getting the, other than you? I know you're having trouble. Anybody not getting the emails? No? Okay. Those emails have lots of links in them to help you review the content that we go over each class. I know I'm throwing a lot of information at you. I get it. I know. So those links are there to help you kind of review what we went over in a little bit more condensed format. Okay. So if you have any questions, please let me know. So over the weekend, you guys had chapters 2 and 3. Did you guys read chapters 2 and 3 in the yellow book? And did you take the tests on page 182 and 183 of the white book? Okay. And then if you graded it, your grading scale is here. If you can tell me either what you got or how many you missed, and I'll do the conversion for you when I call your name. So when I call your name, just give me chapter 2 and then 3. So like 90, 100 or something like that. If you didn't get to it, it's not a big deal. Just say pass. I'll come back around to you next class. Isabella? Okay, very good. Kiana? Julia? Thank you. Jay? Thank you. Erica? Sophia? Victoria? Thank you. Christine? Desleana? Cleanta? For chapter 2? For both? Okay. Do you have chapter 1 for me by any chance? Thank you. Autumn? Autumn, do you have chapter 1 for me? Thank you. Chloe? Thank you. Adriana? Thomas? Thank you. Lisette? Janae? Thank you. Jamar? Thank you. Salith? Thank you. Do you have chapter 1 for me? Thank you. All right. Does anybody have any questions over the homework? Anything you got wrong that you're not real sure why it was wrong or why the right answer is right? Do you want to go over any of the questions? Tomorrow is my game show at 11 a.m. I do it from my other office location, so it won't be in this room, but I'll go live at 11. I'll do 15 practice test questions, very similar to the types of questions you might see on the state exam. Tomorrow's subject is going to be on infection control. So all 15 questions will revolve around infection control. So it's a great way to practice, to kind of see what kind of content you would see on the state exam. And you have an opportunity to win prizes for free. So that's pretty cool too. So remember the game show. So let's see if we can remember what we learned last week before we add to it. How do we know what to do with each patient? We follow the care plan. And it's not just the care plan, it's the care plan, the whole care plan, and nothing but the care plan. That means we can't add to it. We can't take away from it. It stands exactly as it is. What do we do if we can't follow that care plan for any reason at all? Yeah, we just let the nurse know. Absolutely. While we're following that care plan, what's the other half of our job? Observations. And then what do we do with those observations? Report them to the nurse. Very good. Great job. All right. So then we went on to learn the opening. This was on class 1. So every skill starts with an opening. So we do it for every single skill. It doesn't matter what we're doing. Pulse, respirations, feeding a patient, partial bed bath, range of motion, changing a position, helping somebody walk. Does not matter what the skill is. Every single one starts with the opening. What does the opening start with? A knock. And that's important. They need to see and hear that knock because it all goes back to that whole patient rights thing, right? We're learning patient-centered care. So that means that everything we do revolves around the patient. That's right. So knocking is a very important component of that. For the test, when you knock, you don't have to wait for a come in. You can just enter. But in a clinical setting, if that door is closed, give them a minute, wait to hear the come in. Think about all the things you do behind closed doors, right? That you don't want people walking in on. So if the door is closed, that means they want some privacy. If the door is open a little bit, you can just knock and enter. So once we've entered the room, what do we need to do? Greet who? Greet the patient. That's right. So something nice like hello, good morning. Something nice, not just walk in, Mrs. Jones. Right? Remember, it's all about that patient experience. I know these kind of seem like simple rules, don't they? But it's amazing how many times students in the test get this wrong because you're focused on you during the test. Who should you be focused on during the test? The patient. If you can shift your focus and start thinking about the patient, the test goes way easier. Okay. So that's my hardest job, by the way, is getting you guys to start paying attention to the patient instead of yourselves when you're learning. So once we've greeted our patient, we need to make sure that we're working with the right person. So that means we have to identify our patient. How do we identify our patient? Yeah, ask their name or state their name and let them correct us if we're wrong. Either way is fine. Remember, for the test, you will not have an ID band to check. So once we've got all the pleasantries out of the way, good morning, Mrs. Jones. What do they need to know about us? Not just our name, our title too. Yeah. So I am Patty, your CNA today. You want to make sure you tell them your name and title. Guys, you are dressed like every other person in healthcare. They can't tell the difference between a phlebotomist and a doctor. They have no idea who is who. I know these facilities have color coded us, but they didn't give the patients the color code key. They don't know. And honestly, they don't care. They're focused on themselves, which is exactly where they should be focused. So don't just assume that your patient is going to know what you are. Even though it says it on your badge, don't assume. You have to announce. Hi, I'm Patty, your CNA today. Good? Does that make sense? That's really important. I've worked a long time in healthcare and I've got a lot of different stories, but I had one CNA that I was working with. This is when I was working in the main med surg unit of a hospital. And I hated getting paired up with this CNA. I really disliked her. She was rude. She was abrasive. She was mean to the patients. And it was very often that patients would say after she left, "Good morning. Who was that?" So she wasn't announcing what she was. She was just going in and moving patients and turning them and doing things. And because of that, they thought she might have been the nurse. And they were very upset with the way the nurse was treating them. So the things that I'm teaching you actually have a real world application. But the one thing that always stuck out in my mind is that once she went into a room, she assumed that the patients, just remembered her. Now, I want you to stop and think for a second all the different people that come in and out of that patient's room every single day. We have doctors, we have nurses, at least two, right? Because there's an AM shift and a PM shift. You've got other nurses that cover for breaks and lunches. You've also got phlebotomists, EKG techs, pharmacy assistants, dietary aides, volunteers, spiritual counsel, social workers, CNAs. So think about all of those different people. In fact, John Hopkins did a study about this one time, and on average, 17 different individuals enter that patient's room every 24 hours. 17. Now, if you look around this room, right, there's about 15 of us in here. Would you remember every single person in this room if you saw them for less than 3 seconds or 3 minutes? I'm sorry. Would you remember them? No. I mean, you kind of know that they belong because they're in the right colors, but you don't really know them, do you? You would not remember all of their names. You would not remember all of their modalities, what they do, all of their job titles. Why do we expect our patients who are self-absorbed, medicated, sleep-deprived to remember us? It's kind of silly, isn't it? So we have to remember that this is our workplace. We know everybody because we're here every single day. Your patient does not. So we need to treat them with that same respect. And if we leave the room, when we come back in, we need to announce ourselves. "Hi, Miss Jones, it's Patty, your CNA again. I may have just left that room 30 minutes ago or 30 seconds ago to go get a supply. I'm still going to announce myself when I come back in." Does that make sense? It is that important. We're touching a stranger in very personal places. So they really need to have some trust in us. Does that make sense? All right. So we're going to introduce ourselves by name and title. After we get all of that out of the way, we want to describe the skill that we're doing. Now, you can describe this any way you want to. You can say, "I'm here to, I don't know, make your bed. I'm here to do some range of motion exercises. I'm here to feed you a snack." You can put it in your own words. But if you're not 100% sure how to do that and you're nervous during the test, you can pick up that care plan and you can say, "I'm here to measure and record your radial pulse." You can read it right off the care plan. It's fine. I know during the test you're going to be nervous. But in a clinical setting, you kind of have to get used to talking to patients. Because in a clinical setting, if you go in there and you're that dry, they're going to get a little nervous because they're already afraid of everything that's happening in that setting, right? We want to try to make it a little more normal for them. So instead of, "I'm here to perform mouth care to a resident with teeth," "I'm here to brush your teeth." If you were the patient and scared, which one would put you more at ease? Mouth care with teeth or "I'm here to brush your teeth"? Remember that in healthcare, we use a lot of big, scary words. And most of the people that walk into that patient's room hurt them in some way. We're the only people in healthcare that don't hurt the patient, ever. Not our job. We don't hurt. Do you think the patient knows that though? No. So we've got to be really careful here and not stress the patient out too much. Okay. I used to teach phlebotomy. And the hardest lesson I had to get across in phlebotomy, I can teach anybody to stick a vein. That's easy. I mean, drug addicts get it down in like, 2 sticks. Think about it. It's not that hard, right? You're putting a needle into a vein. Drug addicts that are absolutely out of their mind could still figure out how to do it. So that is not hard. The hard thing is to make sure that we're doing the process correctly and putting our patient at ease, because what happens with phlebotomists is they walk in with their little tray of tubes and their needles, and the patient freaks out. And their anxiety goes sky high, and that releases a ton of chemicals into the bloodstream. And now the blood that we're pulling out is not an accurate portrayal of the patient's baseline. Do you guys see that? It's like what we do is going to matter in the lab. So putting patients at ease is a huge part of being a phlebotomist. That's the hardest thing I had to teach. Not tubes and order of draw and all that. That's technical. We can learn that. We can memorize that. That's easy. But being able to put your patient at ease so they don't flood themselves with all kinds of neurochemicals and hormones and different things that are going to really mess up our blood sample, that's the hard part. Does that make sense? So we've got to take a page out of the phlebotomy book and be able to put our patients at ease too. Okay, good? Makes sense? All right, so we're going to describe that skill, hopefully in a way that the patient understands what we're doing, because we need to get something from them. What do we need to get? Consent, permission. Yeah, is this okay? If we're doing our job right and putting our patient at ease, this is what they're going to say. Of course, thank you. We're going to make them feel like we are there to help them. That is our job. But I've seen way too many CNAs that go in there and try to boss the patient around. Nobody elected you. You are not in a position of authority. You are there to help. That is it. Simple. Help. And help isn't help if it doesn't help. Okay. I knew I forgot to do something. Help isn't help if it doesn't help. All right, once we get permission from the patient, we're going to close that. Is the curtain clean? What do we want to do after we close that curtain? Wash our hands. Very good. Get rid of those cooties. After we've washed our hands, then we can go gather our supplies. Very good. We can only touch our supplies with what kind of hands? Clean hands, because the supplies are clean. But now we're getting into supplies. So remember that this is our big neon principle we have to remember. For the test, do not touch the patient until your hands are clean. If you touch that patient before you've washed your hands, it can be an automatic fail. The evaluators are going to look at everything you've touched before you touch the patient. Okay. All right. So now we have to think about supplies. And one of the supplies we have to decide on is gloves. And this is part of the big four. Good morning. So remember, the big four is skill rules, opening, glove rules, and closing. They apply to every single skill that we do, every one. Okay. So we have to start thinking about gloves. Do we wear gloves for everything? No. If we wear gloves for everything, we stop paying attention to what we're touching with those gloves, and that ultimately is going to put our patient at risk. So how do we know, if we're not going to wear them for everything, how do we know when we should be wearing gloves? What 3 rules? If we're going to touch body fluids, personal skin, and non-intact skin. Absolutely. So guys, this is a question for tomorrow. Okay. Non-intact skin is any skin with a hole in it, a scratch, a wound, a sore, a rash, an incision, any skin with a hole in it. So like this is intact skin, right? There's no holes here. This, I don't know if you can see it, is non-intact skin. In fact, I was bleeding yesterday. Non-intact skin. Now I've got a hole there. That hole can let pathogens out, but it can also let pathogens in. So if we're going to touch any body fluids, personal skin, or non-intact skin, we need gloves, but it goes both ways. If I have non-intact skin I'm going to touch the patient with, I need gloves. Good? Make sense? Remember, they're the ones at risk. So if we decide that we need some gloves, what's the first thing that they should touch? The patient. That keeps your gloves clean for the patient. Super important. Now, once we have gloves on, we have to pay attention to what we're touching in the environment with those dirty gloves. So if we put gloves on, we touch the patient, we do whatever we're going to do with the patient, and then we touch the bed controller or the curtain or anything, a cup of water, and hand it to the patient. We're just spreading those cooties everywhere. So minimize the objects in the environment that you touch with soiled gloves. Always be aware when your gloves are soiled, what am I touching? And then we have to know how to remove our gloves correctly. And can anybody tell me how we remove gloves? So pinch it up here. Don't go under. Pinch up, pull off, and then go under and pull off. Good? Good. Okay. So now that we've done our opening, we've evaluated if we need gloves. You looked at the patient, figured out, do I need gloves for this skill? Now we're going to get the rest of our supplies. So if I'm going to get supplies, I need a clean place to put them. How do I create a clean place? I'm going to use a barrier, and that's barrier rules. Remember, this table is not clean. So I'm going to get a barrier and put it on the table to create a clean surface, right? We need a clean surface for our clean supplies. And we're only going to touch our supplies with clean hands. What can't those supplies touch? Your uniform. Why? Yeah, it's dirty. It's leaned up against sinks and brushed up against the curtain and leaned against the bed and knelt on the floor and all of those things. So when should we get that barrier? If our supplies can't touch our uniform, when should we get the barrier? When we get the rest of the supplies? Before the rest of the supplies. So we're going to go over and get our barrier, put it on our table while we have two hands to spread it out, and then go get the rest of our supplies. Good? Questions? Okay, great job. We also learned about privacy blankets. Remember, we learned about this with dressing a resident, right? So we're going to use a privacy blanket anytime the patient is uncovered or undressed. Is our care plan going to tell us to use a privacy blanket? No, these are principles we have to know. Nothing we're talking about now is going to be on that care plan. The care plan isn't going to tell you supplies can't touch your uniform. Care plan isn't going to tell you you need gloves for this skill. Care plan isn't going to tell you the patient's going to be uncovered, so keep a privacy blanket over them. Care plans don't tell us this information. We have to learn it. So anytime the patient is uncovered or undressed, and we're going to apply this blanket to keep our patient warm and covered. Remember, there's two things here that privacy blanket is doing. It's protecting the patient from you, because you're a stranger, but it's also keeping the patient warm, because remember, there is a big difference in the temperature that your patient is feeling and the temperature that you are feeling. Okay, we're going to talk a little bit more about that today too. So anytime the patient is uncovered or undressed, we'll use one. Do we pull the sheet down and then put the blanket on? No, because that exposes our patient. We want to put the blanket on over the sheet and then pull the sheet down underneath. That means the patient is always covered with something. All right. What can't we do with that blanket? Shake it or snap it. Why? Yeah, pathogens in the air. Icky. And then if we're going to use a privacy blanket, when we remove it, we want to remove it after we remove our gloves. We'll get into this a little bit more as we go, but remember that the privacy blanket gets removed after you take off your gloves. And you're going to go wash your hands after that, so it's okay. All right, so let's move on to linen rules. Now, linen rules, we learned, are almost all repeats of other rules that we've learned. Okay, so what can't touch your uniform? Anything, but linens especially. Yeah, because if we're going to use a washcloth right up in the patient's eyes, nose, and mouth, remember that these are all portals of entry. If you've held those linens right up next to your uniform and your uniform is not clean, you're putting pathogens directly in the doorways of your patient. Do you guys see how dangerous that is? Because this isn't the pathogens on this person, on her uniform, isn't just this guy's pathogens. They're that guy's pathogens and that sink's pathogens and that curtain's pathogens and pathogens from the Jiffy store that she stopped at this morning to get her whatever, Circle K, you know, right? Think about that. We wear these uniforms in our home, in our car, everywhere we stop before work, walking into work, and then in our work environment. Are those uniforms clean? Now, I remember, because I am really old, I remember way back when hospitals had locker rooms and showers, and you didn't wear your uniform to work. You went to work, you put on a uniform that they provided, so it wasn't brought in from outside. You wore that uniform while you worked. At the end of your shift, you showered, changed back into your clothes, and went home. Now, I think that's a much better way of addressing infection control. When you guys leave this room, how many of you guys go straight home, no stops at all? Very few. Yeah, I don't. I stop at Publix or Winn-Dixie or wherever I need to stop, right? It's not a big deal because we're in a classroom setting. We're not working with real people. But if we're doing that, now I have noticed in every place I've gone, I'm not the only one there in scrubs. So if we know that at least a portion of these people are coming from an environment that is absolutely filled with all kinds of big bad pathogens, and now they're roaming our community with all of those big bad pathogens on their uniform, do you really think that that's safe for our community? So we have to kind of think about these things, right? I'm okay going into an environment because I know that I'm not working with patients. But when I did work with patients, I didn't stop. I went home. Incidentally, our medical community gets this all wrong all the time. You know those jackets that people wear over their, like scrub jackets, lab coats, right? That's what that was all about, by the way. They weren't a fashion choice. You put a jacket on over your clothing when you left the clinical setting to contain all of the pathogens if you had to go somewhere. Right now, we look at them as fashion choices. I've got 16 different jackets over there, right? People aren't thinking about how much of this uniform would it cover so I don't spread pathogen. They don't think, oh, I don't like this zipper. I'd rather have snaps. I don't like the cuffs. It's not a fashion choice. It's an infection control issue. but people don't recognize that. So we've got to start thinking beyond, right? Beyond. And this was especially important during COVID. So it got us thinking a little bit more on the infection control side of things. So just be aware of it. But remember that your uniform is not considered clean. We don't want to hold those linens up next to it. What kind of hands do we have to get our linens clean? And what should we not do to any of the linens we're using? Shake them or snap them. Now, we're going to skip 2. We're going to come back to these later. And what do we do with any linens that we did not use? Discard them. We cannot leave them in the room for later. Remember that anything that is out of your sight is considered contaminated. That's actually a question for tomorrow. I'm giving you guys all the answers. Look, you guys can win. All right, we'll go over the other 2 a little bit later as we go through the program. And then we're going to end every skill with the closing. What kind of an environment should our patient be in? Clean, neat, orderly, tidy. Whose job is that? Housekeeping's? Us, CNAs. That's right. Housekeeping helps, certainly. They do a lot of the heavy lifting, the mopping and the cleaning of the bathroom. But ultimately, it's our job to make sure the environment is neat and clean. Okay. Good rule of thumb, always leave your patient looking better than you found them. That's just a really good rule of thumb. What position should the bed be in? Lowest position. Yeah, I'm not talking about the head of the bed. I'm talking about the entire bed. Head of the bed at the end of the scale, that's just whatever the patient wants. Entire bed must be in the low position, right? You know, the example I give for this is the floor moves, right? Right. So if you raise the bed, the floor moved. Yeah. Anybody hear about the sinkhole in Weeki Wachee? Yeah, that floor moved, didn't it? That was a mile from my house. Yeah. I can actually walk there from my house. Yeah. So when I saw that, I'm like, man, that floor really did move, didn't it? Scary stuff. Thursday morning. Yep, Thursday morning. Huge sinkhole opened up, about 50 feet deep. I mean, this thing was massive. Massive. They're going to fill it in and build a house on it. I'm serious. That is what they are doing. They are filling it in and building a house on top of it. All right. So remember, the bed needs to be in the low position. What word do the patient or do the evaluators need to hear? Are you comfortable? They need to hear the word. Make sure that you say comfortable. Are you comfortable? Now, a lot of people say, is there anything else I can get for you? Yes, it's nice. That's nice, but that's not comfortable. They need the word. Be really careful here. And part of comfort is emotional comfort. So we want to offer them something for entertainment, stimulation, distraction, whatever. So for the test, just offer them a magazine. It's the easiest way. Would you like a magazine? One of the comments I got not too long ago on my YouTube channel is, boy, Miss Patty sure does like her magazines, doesn't she? All right. You want to address preferences. So, you know, magazine, TV remote, head of the bed, that type of thing. And your patient must be covered either with a sheet or clothing. I don't care, but they have to be covered. No knobby knees. So once we've got all of that out of the way, we can open the privacy curtain because the patient doesn't need it anymore. Once that privacy curtain is open and the call light is placed in their hands, keep that in mind, in their hand, then we can go wash our hands. Now, the order of all of this doesn't matter. However you want to do it, I don't care. They don't care. Nobody cares. The order of this does not matter until we get to here. This, we're encountering patient cooties every step of the way. We have to go wash those off. Once we've washed those cooties off, should we come back and do any of these steps? No, because if we do, we're going to re-cootie up. So if we're over there at the sink and we look over, realize we didn't give the call light, we didn't open the curtain, oh my gosh, I got to do those things. And we go back over to the patient, what do we need to do? Rewash our hands. So this step, the order is critical. It has to come after all of these. So once we washed our hands, then we can document if we need to. Remember, there's 4 skills that require documentation. So if we need to document, we're going to do it after we wash our hands. But then our principle is we have to end skill with clean hands. So if we document, what do we need to do? Wash our hands again to meet that checkpoint. End skill with clean hands. All right, good. Questions on what we've learned? So if we look along the back wall, we know skill rules. There's 11 principles we have to learn. We know skill rules. We know the opening. We know barrier. We know glove rules. We know privacy blanket. We learned most of linen rules. And we've learned the closing. So out of the 11 that we have to learn, we've already mastered 7. And we're only a week in. Easy. Right? Remember on day 1, I told you we're going to learn all of that? But I told you I'm not going to have you memorize it. I'm going to have you learn it. And we're going to keep reviewing so I can make sure that you get all of this. But remember that all of this is in your book. All of these principles are in your book. They're also on the worksheets that you get at the end of every class. So that's a really quick and easy way to review. And then we have the flashcards too, if you want additional review for supplies, steps of the skill, and these principles. So the flashcards actually have, when you're looking at the flashcards, they actually have the blanks, just like what I have here. So the flashcards actually do what we're doing here with a review. All right. Whoops. Let me go back here. Okay, so let's start reviewing some of the skills that we've learned so far. So anytime that we're doing any skill, we have to support extremities, right? So for pulse, we're specifically going to support the arm. What happens if I have somebody's arm kind of hanging out here in midair? What does that do to their pulse rate? Yeah, it raises it. So are we getting an accurate reading? No, so we need that elbow supported. Okay. Pulses are always reported over what time period? Reported over 1 minute. Yeah, how long do we have to count for? Okay. Yeah, there it is. Care plan. So yes, for the test, the care plan is going to tell us to count for that whole minute. You're absolutely right. But in a clinical setting, we're going to go by the care plan because it may be different. What is our normal values for pulses? 60 to 100. What finger can you not use to take a pulse? Thumb. And when we're using our index and middle finger, what part of the finger should we use? The flat or the tip? Tips. All right. Radial pulse is located where?
The line.
Yeah, the lines. Is it at the thumb side or the pinky side? Thumb side. All right. When we're counting with the evaluators, we're going to say start and stop so they know when to start and when to stop. And we're going to get the same reading, hopefully. But we can be off by how many beats in either direction? 4 beats in either direction and still be considered accurate. In Florida, how many evaluators do we have to count with? 2. And this is a counting skill. That means we have a number in our head. What are we going to do with that number? Write it down. Yeah. If somebody asks you, hey, what's your name? Victoria. Victoria, go take a pulse in room 212 for me. And you go take the pulse in room 212 and it's in your head. Does it help me? No. If I ask you to do something, that means I need the information from whatever you're doing. It's not busy work. So if you don't document at the end of this skill, you will fail it. You'll fail it because the person that needed the information didn't get it. It doesn't matter that you did it. That has no bearing on this whatsoever. The person who needed it didn't get it. Does that make sense? All right. Dressing a resident. We want to ask about clothing preferences, choices. What do you want to wear? Do patients have the right to choose their own clothes? Yes. Absolutely. Even in a hospital. Do you guys know that? We put patients in gowns because it's convenient. But do you know in a hospital they are allowed to wear their own clothing? You guys know that? Yeah. Clothing is a right. You get to choose what you want to wear. Clothing is an external reflection of your internal feelings. Some days I get up and I want to be bright and colorful, and I put on yellow and orange and pink and green. Other days I'm like, it's a Monday. Black, that sounds good, right? So clothing is an outward expression of how we feel internally. Your patient has the right to express themselves, and we have to give them that right. So we're going to ask about their clothing preferences. When do we get that clothing? Before or after we undress them? Why? Okay, so we can ask them. Why else? Privacy, yeah, exposure. If we get somebody completely naked and leave them there in the bed, even covered by a privacy blanket, it's still a little bit unnerving, right? Because you're laying down. How vulnerable do you think you are laying in a strange place, undressed, with a stranger in the room? So we have to stop and think about this from our patient's point of view, don't we? So we're going to get clothing before we undress. Anything that we lift, we always lift from below, supporting at the joints. And how do we know which arm to undress first? USA. What does USA mean? Undress strong arm first. And then we'll dress the weak arm first. Good? That allows the clothing to just slide right off that weak arm, no movement required, and allows the new clothing to slide on that weak arm, no movement required. We're going to make that stronger arm do all the work. We don't want to overextend or force movement. Remember, we don't want to snap those fingers back when we're trying to put sleeves on, because the fingers can get caught in the cuffs of the sleeves and snap backwards. We're going to place all dirty items in the hamper. Don't leave them on the floor, the bed, the table. Make sure you put them away. And which hand should the call light be put in? Stronger hand, yeah. So we didn't do range of motion yet. I'm going to skip this one. We're going to come back to it. It's okay. We're actually going to cover this today in a little while. So when you're looking at all of this is what we were just talking about a minute ago. We've got 11 principles here, and we only have 4 that we need to learn. Good? We'll keep reviewing. All right, so let's get into that. Let's go to page 116. Let's see here. Oh, nice. All right, Donna Williams says, good morning. I did my exam on the 28th and passed both exams. Congratulations. Good morning, Valencia and Bunja. And this is a good question. Joe Bengals says, will they ding you in the exam if you wash your hands more than once? And the answer to that is no. You can wash your hands as many times as you want to in the test. If you're trying to remember what the next step is, you can go wash your hands to buy yourself some time. It's okay. They're going to grade your hand washing at the beginning and the end of the first skill. Now, after that, after your first skill is done, they're going to tell you you can simulate hand washing. So simulate just means say. I would wash my hands here. I am washing my hands now. You don't have to go to the sink. You don't have to pantomime. You don't have to, it's just say. You would say when you would wash your hands. Now that's a time-saving measure, because where do those evaluators want to be? at home in their pool drinking their Mai Tais. They do not want to be watching you wash your hands a million times. Let's play this out for just a second so you can see what I mean, okay? So let's say we have 8 people here testing. So 1, 2, 3, 4, 5, 6, 7, 8 people testing. Each one of you gets 3 skills. And you have to wash your hands before every skill and after every skill. So you're going to wash your hands before skill 1, after skill 1, before skill 2, after skill 2, before skill 3, after skill 3. How many hand washings is that? 6. And so are you, and you, and you, and you, and you, and you, and you. So when you multiply that together, 6 times 8, any math majors here? 48. That means as evaluators have to watch 48 hand washings. Talk about a boring job. So they're going to watch you at the beginning and the end of your first skill. After that, you can say when you would wash your hands, but they're not going to require you to do it. That's going to reduce the amount of time it takes to do this particular test. Good? Okay. Sorry, guys, I'm going to have to sit today because my knee is buckling. So I'm going to sit for just a second. Sorry. Okay. All right, one more question here. Denia says, good morning. During the test, do I bring regular clothes or scrubs? So that's a great question. For the test, you can wear anything you want. There is no dress code for the test other than closed-toed shoes. And I noticed you were wearing sandals, so you need to be in closed-toed shoes for the test, class 2, but for the test. They don't care about anything else. You want to wear cutoffs and a bikini top? Go for it. You want to wear jeans and a t-shirt? No problem. But I firmly believe look the part, act the part. Okay? So if you go dressed in scrubs, it will automatically elevate your performance because you're now dressed like you're going to be acting. Otherwise, you end up with something like imposter syndrome when you're testing because you don't look the part. You feel like you're just kind of going through the motions. It's going to feel weird. Now, anytime you put scrubs on for the first time, it feels weird, which is why I make you wear them to class because I want you to get all that weirdness out in here. So by the time you get to the test, you're comfortable wearing scrubs. Does that make sense? Yeah, absolutely. We're going to be bending and lifting and moving and all the things that we would be doing in a clinical setting, which is what scrubs are designed to do, move with you. So it's a good thing to wear scrubs because they don't restrict your movement during the test. Okay, but you're not required to. You are not required to. You will see people there that are testing in yoga pants and a t-shirt. I personally would prefer that you be in scrubs. It's a little more professional. Good? Questions on that? Okay. All right, so let's go to page 116 and let's learn hand and nail care. So when you're looking at this page, first thing that we want to look at are the principles involved. So going down the side here, you can see that skill rules, opening, glove rules, barrier rules, linen rules, washing rules, basin cleaning, hand and nail care, and the closing is what's going to tell us how to do this particular skill. That's a lot of steps, guys. Wow, that's a lot of steps. They're all spelled out for you over here. All the banners are displayed for you. These are your skill-specific steps. We're going to go through step by step. I have a video for this. If you look at the bottom of the page, you can see somebody with your level of experience should be able to do this in 11 minutes or less. It's going to be done on another testing student, which means you might be the patient for this. That student is going to be sitting in a chair, and documentation is not required for this skill. So we have 11 minutes to do this skill. What is the skill? Hand and nail care means we're going to wash one hand, rinse one hand, dry one hand, clean under the nails of one hand, file the rough edges of the fingernails on one hand, and put lotion on one hand. I don't know about you, but that does not take 11 minutes. Wash, rinse, dry, clean, file, lotion. It's going to take you probably, because you're a little slow, you're new, probably about 5 minutes to do. They give you 14. So understand that the test is not about rushing you. They're going to give you way more time than you actually need to do these skills. The people that time out are those that have absolutely no idea how the skill is done, and they start over 15 times. You can start your skills over during the test. You can. So if you flub it up really badly and you just are not happy with your performance, you can say, well, who are we talking to though? The patient or the evaluator? The patient. You can say, oh my gosh, I don't know where my brain is right now. Let me just start over. Let me take a breath and I'm going to start over. And your patient and the evaluators will keep up. Okay, you can start over. But let's talk just a little bit about timing on the state exam. So we're going to come back to this in just a minute, but go to page 71 for me. Because this is a question that comes up quite a bit when we start talking about timing, when we get into the skills. All right. Give me a number 1 to 11. 10. All right. So the test, Prometric, randomly picked skill set 10 for you to perform. Guys, that's who picks your skills. The evaluators do not pick your skills. The evaluators do not pick your skills. They have no control over it. They aren't allowed to change them. And that's because they're trying to eliminate bias. If you parked in my parking spot this morning, I'm probably not going to be real happy with you. So I'm going to give you the hardest skill set there is because I'm not very happy with you. They're removing that. Does that make sense? Okay. So the evaluators do not have any control over this. None. It's already coded into your ID number. They can't change it. So the test, the computer randomly picks skill set 10 for you to perform. Now, skill set 10 is measure and record pulse, perform passive range of motion to elbow and wrist, and provide partial bed bath to a resident in bed. Those are your 3 skills. That's what you're going to do for the test. Now, they're also going to tell you as they read that to you that you're going to have 36 minutes to perform this set of skills. Now, if you look at this page, you'll see that I have an amount of time here specific to this skill. Okay. So we're going to use these skill timings, but we're going to add to it as well. Now, on page 171, or I'm sorry, on page 71 of your book, you'll see in the middle of the first column a chart that has all of the skills and the times associated. So if you look on that chart, how much time do they think that somebody with your level of experience should be able to take a pulse in? 5 minutes. So anybody that has a pen, take your pen and write down 5 minutes on the side of the page somewhere. 5 minutes. So passive range of motion, how much time are they giving you for that? 4 minutes. Says all range of motion, 4. So write 4. So 5 plus 4 is 9. Partial bed bath. Can anybody see how much time that is? 19. So 9 plus 19 is, any math majors? 28. I told you had 36 minutes. So 28 and 36 are not the same. Where's the rest of the time come from? They're going to give you an extra 3 minutes just for hand washing. It does not count on your skill time. Extra 3 minutes just for hand washing. They're also going to give you, so that brings us to 31. They're also going to give you an extra 5 minutes for thinking. They call it transition time, right? When we go from skill 1 to skill 2, we got to set up, right? But it's really thinking time. So don't rush on the skills. You have way more time than you need to do all of the skills. And where you get into trouble is when you start to rush, because then you skip steps. But what happens if you do go too slow and you're starting to run out of time? What happens there? Well, it's not an automatic fail to run out of time. It is not an automatic fail. They're going to give you a 5-minute warning. So at 31 minutes, they would say 5-minute warning. Now, you want to get as many of these checkpoints checked off in that 5 minutes as possible. Do you guys remember seeing those that I showed you, the colors, right? Half of all the checkpoints are red and green. You guys remember that? Right? So if you get a 5-minute warning and you do nothing more than the opening and the closing on the next skill, you've got like half of your checkpoints done. Does that make sense? So when you get a 5-minute warning, if you start to go, my students never go over time. My gosh, and like, I don't know, I would say at least 10 years since somebody has gone over time. I mean, it's been significant. My students do not go over time. But if you get that 5-minute warning, remember to get as many checkpoints in as you can. And this is where I keep telling you to learn your opening and your closing backwards and forwards so you can do it, off the top of your head. So if you get a 5-minute warning, you've got a whole skill left to do, you should be able to get your opening and closing done pretty quick. Like, hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to give you a partial bed bath. Is that okay? All right. I'm going to close your curtain, wash my hands. Remember, you're going to simulate because it's skill number 3. I have clean hands. I'm going to go get my barrier, go get my supplies, do as many steps as I can. And if I'm still running I'm not quite done, but I'm still running really low on time, then I'll go right into my closing. Thank you very much, Miss Jones, because I want those checkpoints. Remember, half of those checkpoints are the closing. So if my bed bath isn't done and I don't get those checkpoints, at least I'm getting my closing out of the way. Does that make sense? My students don't have a problem with that. But if you get a 5-minute warning, try to get your opening and your closing and as many checkpoints as you can in, because that's what's going to be held against you. Anything you didn't get to, no check mark. Deficiency. Good? Make sense? So when they give us 11 minutes to do this skill, that's crazy. Crazy. All right. So let's figure out how to do this skill. Okay. So we know most of these principles already. We know skill rules, the opening, glove rules, barrier, and linen rules. And we know the closing. So we have a couple of things that we have to learn. Skill specific, we'll get to. But there's 2 principles here that we haven't learned yet. And they're important for this particular skill. So we're going to take some time to learn washing rules and basin cleaning. And these 2 go together because with washing, I've got to have a way to carry water. So that means I've got to have a way to clean that basin after. So these 2 go together. They're kind of like sisters, okay? They go together. So let's learn about washing rules. You go to page 112, you can see the washing rules there. Again, I've got a video for you. I always have a video. The next edition of this book, I'll actually have QR codes. Oh, that was nice. That's nice. Yeah. I can't believe I didn't think about putting it in this book. All right, so if you see over here, featured in, you can see that there's going to be 5 skills that we're going to use washing rules with. So not as much as privacy blanket or glove rules or linen rules, but there's a few, right? These happen to be the longer skills that we do. Anything that we wash is going to take a little bit more time. So we're going to learn this particular principle. Now, I've got notes for you on page 113. So you don't have to take notes, but we're going to kind of go through this. This takes me just a little bit of time to teach you. So I want you to think about how you bathe, right? You get into the shower. You probably get wet. Then you apply soap, lather up. And then what do you do after that? Rinse. You rinse. Why do you rinse? Why? Yeah, you don't want to stay soapy. Makes your skin feel funky, doesn't it? Yeah. So is rinsing important? Do you think you'd be comfortable getting out of the shower all soapy with shampoo still in your hair and having to go through your life like that? No. So rinsing is a pretty important step, isn't it? The problem is that when we're doing it on somebody else, we forget to rinse. You will forget to rinse. Statistically, about 25% of you, when you're practicing, will forget to rinse. So we're going to spend some time remembering why we should not forget to rinse. Okay? I know this is a very simple step, but when you start doing this on other people, it's a really easy step to forget. So we want to talk about it. We'll get there in a minute. So in order to rinse, we don't want to put soap in our bathing water because that water, that basin of water that we're going to get, has to be available for washing and rinsing. If we put soap in that water, we have nothing to rinse with. Now, some of you, hold up, some of you are going, well, why can't you just have 2 basins? One for washing and one for rinsing. I know some of you are thinking it. So let's talk about that for a second. How many of you guys have ever gone to a hospital? How many of you guys got a bill? Yeah. Hospital care is not cheap, is it? But the thing about hospital care is that they don't give you an itemized bill. They just give you a bill. Hey, you owe $26,000, cash or check, right? They don't give you an itemized bill unless you ask for one. And everything that was used on you in that setting was billed to you, including those basins. And those basins are anywhere from $26 to $42 a piece, roughly, depending on the hospital. Now, our 3 hospitals here in the county actually made U.S. News and World Report top 10 most expensive hospitals in the nation. All 3 of ours in the county are on a top 10 nationwide list. That should scare you guys. Top 10 nationwide list. All 3 of our hospitals on it. Now, the list was from like 2014 or so, a while ago. But I don't expect that it has changed much. Everything that is used on the patient gets billed to them, including those basins. So if it's the equivalent of, this is how I like to explain it. Imagine, how many of you guys go out to eat? Anybody go out to eat? Yeah. So imagine going out to eat and they don't bring you menus. No, they're going to decide what you want. They don't give you prices, but you're going to have to pay when you leave. They serve you what they want. They decide how much to charge you, and then you have to pay it before you leave. Would you go back there? And that's what we do in healthcare all the time. We don't tell them what we're going to charge to them. We just give them a bill at the end. and they have to pay it. And if they don't pay it, they will take you to collections. They will. One day every month at the Hernando County Courthouse is medical collections going before a judge. They will take you to collections. So I don't think we should be charging things to patients that they don't need to be billed for. Does that make sense? You don't need 2 basins to do this skill. You only need 1, as long as you don't put soap in the water. Make sense? Starting to learn a little bit about healthcare, how healthcare works in America. Yeah. Yeah, I actually know somebody who went to the hospital, had a very serious infection, had no insurance, and the bill was well over $250,000. Yeah. What do you do? I couldn't pay it. There's no way.
That's too much money.
There's no way.
Don't pay it off till you're 100 years old or more.
Yeah, there's no way. Crazy. So we've got to be a little bit smarter than that and not just use a bunch of supplies because we don't care if they get the bill. That's not really how we need to approach this. We want to be smarter about this. Does that make sense? Okay. All right. So we're not going to put soap in the water. Basins are no soap zones. So as long as we don't put soap in the water, it's just water, and we can then use it to rinse with. It also cuts down on the cleaning at the end because we only have 1 basin to clean. Okay. So whatever we wash, we rinse. Whatever we rinse, we dry. I want you to remember that because remember I said that rinsing gets skipped a lot. So if you remember this little saying, and it's super simple, isn't it? Whatever I wash, I rinse. Whatever I rinse, I dry. If you remember that, if you just keep, as you're doing your skill, if you say that to yourself, when you put soap on, whatever I wash, I rinse, it'll trigger your brain to remember to rinse. Okay, whatever I wash, I rinse. Whatever I rinse, I dry. Don't leave your patient laying there sopping wet. Now, we do this on ourselves all the time. I mean, we bathe ourselves and we never skip a step and we've got this down, but you're on autopilot when you're doing it on yourself. You're not thinking about the steps. You're just on autopilot. When we're doing it on somebody else, we now have to start thinking about the steps. Otherwise, you'll skip one. You just will. So whatever we wash, we rinse. Whatever we rinse, we dry. And since we have to rinse the soap off the skin, we're not going to add soap to the water. That keeps our water clean for rinsing. All right, so let's think about this for a second. We have done our opening. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to whatever. Is that okay? Close curtain, wash hands. So now I've got clean hands. I went and got my barrier because I need supplies. I went and got my barrier first, put it on the table, got all of my supplies, put those on the table as well, grabbed a pair of gloves, put those on the table. Now I'm ready to go get water in my basin. I have washed my hands, and the only thing my hands have touched are clean supplies. Can I touch that faucet with these hands that are going to touch the patient? No. So remember that you have clean hands. When you take that basin over to the faucet to get water, that faucet is not clean. So because the faucet is not clean and your hands are, we're going to use a paper towel. And you don't need a paper towel when you're washing your hands because your hands are dirty. They're touching a dirty faucet. No big deal. Dirty can touch dirty. But in this situation, your hands are clean. Does that make sense? Now, if you want to cut this down, if you just want one rule to rule them all, right? To use a paper towel for everything. Don't touch faucet at all, ever. That's fine. You can do that. No problem. But I want you to have a bigger understanding of infection control. Does that make sense? You look confused.
Yeah.
Okay. Does that make sense? Okay. If your hands are clean, you need a paper towel to turn the water on. Good. So now we get to this part. And this is where the majority of this lecture is going to be situated, because your patient is not like you. And we've got to kind of understand this on a little bit more fundamental level. So when I check water, I'm going to use the inside of my wrist right here, the inside of my wrist. This has the most nerve endings and the thinnest skin. So this is pretty accurate for what my patient is going to feel. So the inside of my wrist. So that water against my wrist should feel warm, not hot, not cold, just warm. Does that make sense? Just warm. Now, the reason for that is your patient is going to interpret temperature differently than you do. And a lot of that has to do with age. So because I think the water is okay, I'm going to take it over to the patient and ask them to check it. And if they say it's okay, we're going to move on. If they say, no, it's too hot, I'm not going to argue with them. I'm going to go cool it down. If they say, oh, that's way too cold, I'm not going to argue with them. I'm going to go warm it up. I'm going to listen to my patient. Does that make sense? Everybody has different bathing preferences. How many of you guys like your showers cool? Because it's like super hot out. Cool. Okay. How many guys like your showers kind of warm? A little warm. How many guys like your showers hot enough to take skin off? Yeah, if it's not steamy, boiling hot, it's not hot enough for me. I want to leave skin in the shower. I mean, I want hot showers. So if you bring water to me that's super cool, I'm probably going to tell you, oh no, that's not going to work for me. Go warm that up, right? Because I have a different preference. Now, my husband likes cool showers. So if I bring my temperature comfort water to him, he's going to go, oh my gosh, you trying to burn me? That's too hot. Go cool that down, right? Everybody has different temperature preferences. Does that make sense? So we have that problem. But now we've got a deeper problem as well when it comes to temperatures. So remember, everybody has different preferences. But as we age, this whole system gets a little wonky. And let me explain why. When we are young, we have layers of skin, fat, and muscle that are pretty thick. In fact, babies, little babies, right? When they're good and healthy, they're little chunks, aren't they? Right? Roly-polies. And they've got big layers of skin and muscle and fat, not so much muscle, but skin and fat. They're developing their muscle, right? We're going to explain why in just a minute. As we get a little bit older, each one of those layers is going to shrink down. So middle age, we don't have the same thin skin thickness. We don't have the same fat thickness, and we start to lose muscle mass. As we get old, this really starts to show up. Have you ever seen an old person's arm? It looks like skin over vein over bone. I mean, there's nothing there. It's just, you can actually see the veins, right? So how do you go from big, thick layers down to being able to see the veins right there under the skin, like road maps? It's because as we age, our body changes. And this layer of fat goes away. It gets resorbed in our extremities. So, okay, if we know that happens, now we got to figure out, what does that layer of fat do and how is it going to affect my ability to care for the patient? So that's what we're going to focus on right now, okay? So we know as we age, that layer of fat goes away. You can see it. You can see this next time you're in Walmart or Winn-Dixie or any of the stores, and there's an old person, look at their arms. You can physically see this with the naked eye. Won't be long, you're going to be able to see it on me because I'm getting old. You start to see it on the backs of my hands, right? I'm losing my fat layer. I could stand to lose it a few other places, but life isn't that kind. So what does this do? Why do we care, right? So when we have a layer of fat along our entire body, that layer of fat is doing two things. It is keeping inside temperatures in and outside temperatures out. So I want you to kind of understand this. We're going to explain it in a little bit different way other than medical, okay? So if you were to walk outside today, let's see, it doesn't tell me the temperature, 89 degrees. So if you were to walk outside today, it is 89 degrees out there. How would you classify that? Hot. Yeah, we got the added benefit of humidity, yay. But it's hot. 89 degrees is hot. It's going to be probably around 94 today by the time we get out of here. Hot, right? Everybody can agree 94 degrees is hot. Now, if you reach over and touch the person sitting next to you, they don't feel hot, do they? They just feel normal. But what is a normal body temperature? Yeah, we're going to switch those digits. It's 98.6. You're on the right track. 98.6. Let's make easy numbers. I don't like decimals. They're too complex for my brain. So let's just go with 98. Okay, 98. Now, we just said 89 was hot. 98, man, that's really hot, isn't it? And yet you guys are all about 98 degrees, give or take. So if you reach over and touch her, she is 98 degrees. Hot. Everybody good with that? Now, this is so critical in the human body that if we drop below 95, we can die. It's hypothermia. If you are at 93, you are dead. That is how narrow our body temperature has to be regulated in. That's pretty narrow. Okay, 98.6 is normal. 95, hypothermia. It's actually almost 96. Hypothermia. 93 is dead. Dead. So, you got to stay with me here, okay? So, if we know that we have to stay around 98 degrees, that means, and we know that 89 is hot, right? That means we have to have a mechanism to keep our bodies at 98 degrees because the environment isn't doing it for us. In fact, the environment is doing the opposite. There is a principle, room temperature always wins. Let me explain what I mean. If we have a pie in the oven, let's say an apple pie that we threw in the oven and we cooked it at 325 for 45 minutes and we took it out and it's all bubbly and nice and crisp. How would you just, if you touch that pie, how would you describe it? It's going to be hot, right? It just came out of the oven. It's going to be hot. Leave that pie on top of the oven for a couple of hours. What happens to it? Does it stay hot? No, what happens to it? It cools. And it'll cool down to room temperature. Make sense? Room temperature cools down hot things. But apple pie needs some vanilla ice cream to go with it. So the vanilla ice cream is in the freezer and it's 0 degrees. We take it out of the freezer, and if you touched it, you would call it cold. But if you leave that vanilla ice cream out on the counter For the same amount of time that you left the pie on the counter, what happens to the ice cream? It melts. It reduces or warms up to room temperature. Room temperature always wins. It wins with apple pie, it wins with ice cream, and it wins with human bodies. Room temperature always wins. That means that right now, this room right here is trying to cool me down to about 75 degrees. What happens if I get below 93? I die. So that means my body is fighting room temperature all the time. All the time. So in order for me to stay at 98 degrees, I have to have a mechanism inside me that keeps me warm. We call this burning calories. That's why we call it burning calories. Isn't that cool? Probably never knew that, did you? So when your metabolism burns calories, it creates heat. And that heat is what keeps you at your baseline temperature. So if you're not eating properly and you have malnutrition, what do you think might happen to your body temperature? Yeah, and that's one of the things that we look at when we look at somebody that we think is malnourished. We look at their temperature. Isn't that cool? Pretty neat, right? So that means that your body has to work super hard because remember, room temperature is trying to move your body temperature, right? Your body has to work super, super hard to keep you at 98 degrees. So we have this layer of fat that actually acts as a wetsuit. And as our body creates body heat, that layer of fat helps keep it inside so it doesn't radiate away. It helps keep outside temperatures from getting in and cooling us down. So that layer of fat, pretty important. Keeps you alive. But over our age, we lose it. So what do you think that's going to do to our older patients' temperature? If you take somebody's temperature that is older and doesn't have this fat layer, what could you expect their temperature to be? Lower. So it's not uncommon for our older patients to have slightly lower temperatures. Where you are 98.6, they may be 97.9. A little bit lower than yours. Does that make sense? Do you guys understand why?
Yeah.
Pretty cool, right? But this layer of fat does something else as well. So we have this layer of fat that helps our body heat stay inside, but it also keeps outside temperatures out. Florida is the retirement capital of the world. Now, a lot of the reasons that people come here, and they'll tell you, like if you go across the street to the subdivision and you go knocking on doors, why are you in Florida? Why are you in Florida? Why are you in Florida? The heat. And they'll tell you, I can't handle the cold anymore. I can't handle the cold. And they're right, because they don't have that layer of fat that keeps the cold out. Does that make sense? All right. So when we understand this, that layer of fat has a very important job in the body. And when we lose it, it's going to affect a lot of things. Our patient's perception of temperature. Have you ever gone into grandma's house and you're like, oh my gosh, grandma, it is hot in here. And she's got a sweater on and you're like, are you nuts? It's like 89 degrees in this house. What is wrong with you? Well, she's not able to regulate her temperature well because she doesn't have this layer of fat to protect her. So we kind of have to understand this as we are working with our patients, because it's not just going to affect their temperature perception of the air. It's also going to affect their temperature perception of the water, because that layer of fat acts as an insulator as well. Okay. It helps protect the vasculature, your arteries, your veins, your capillaries, and your muscles from exposure to the elements, to true temperature. It acts as a barrier. But when we don't have that, the way that they feel water temperature is going to be way different than the way you feel water temperature. And this is why we start with water that's just warm. Because to you, it may feel warm, but to them, it may feel hot, because they don't have that same level of protection that you do. Does that make sense? That makes sense? This step, not this one, change the water if it gets cold or soapy. This step, having our patients check the water temperature, is one of the most important steps on any washing skill, because it proves that you understand this whole lecture we just had. Okay, good. If our water gets cold or soapy, we have to change it. So if you remember just a few minutes ago, we learned that this skill, they're giving you 19 minutes to get it done. 19 minutes to get the skill done. In 19 minutes, that water is going to get cold. So you got to speed this one up a little. You take all 19 minutes to do this skill, they expect you to change the water out at least once. If you can get it done in 10 or 12, you don't have to change the water out. Good. Room temperature always wins. Always. Always. All right, so the order we do this matters. Whatever we wash, we rinse. Whatever rinse, we dry. We're going to come back to this step right here in just a few minutes, or in a future lesson, I mean. We'll come back to this step. Whatever we wash, we rinse. Whatever we rinse, we dry. Think about how you would feel if you didn't wash your soap off. This is actually what skin looks like with soap that is not rinsed off, with soap that's allowed to dry on the surface of the skin. That's what it looks like. It makes you very itchy. It dries out your skin. So they are looking for that rinse step. It's an important one. So years ago, years and years ago, I had a patient that wasn't getting rinsed, and she was, I don't know why. I don't know the story behind it. I don't know. But she was bathing herself and she just wasn't rinsing very well. But she was so itchy. I mean, she was scratching grooves in her skin. I mean, she was like a mess. And we thought she had bugs. We tore her whole room apart. We, looked for evidence of scabies. I mean, we were looking for, we thought it was, she was having that bad of a reaction to it. Turns out she just wasn't rinsing. So rinsing is really important. Not rinsing and letting that build up over time can have a really serious effect on your patient's skin. Yeah, that was horrible. Oh, I mean, she was just a bloody mess. All right, so make sure that when you're working with water, we are not spilling it. So we want to wring our washcloths out really well. No drippy wet washcloths. We don't want to get our sheets wet. You don't want water on the floor, on the table. Just try to keep your water confined to the basin. And the best way to do that is to wring those washcloths out really, really well so they're not drippy wet. Anytime we put lotion on, we're going to warm it up first and then wipe off the excess. Don't just squirt cold lotion on your patient. That's no good for anybody. We don't like that. Put the lotion in your hand, warm it up really well, and then apply it. But anything that you apply is only going to absorb so much. your skin can only, it gets what we call a saturation level. So it'll absorb what it can and the rest just lays there. And if you've got lotion that's just laying on the surface of the skin and the patient goes to pick up a cup of hot coffee, what could happen? It can slip. So same thing with a foot. If you put lotion on the foot and you don't wipe off the excess, their foot can slip inside their shoe and that can actually cause injury. So we want to be really careful when we put lotion on, let it soak in, but anything that's left, we're going to remove with a towel. That keeps our patients safe from us. All right. So that's washing rules. Now, basin cleaning is complex. For the test, we are simply going to rinse, dry, and store our basins. That's it. That's all we have to do for the test. If you use a basin, you rinse it out, you dry it out, you put it back where you found it. That's all we're going to do. We don't disinfect. We simply rinse it out, dry it, and put it away. Does that make sense? Everybody good with that? Those basins are only single patient use. We don't pass this person's basin over there to that person. No one else uses that basin but your patient who's paying for it. That's it. So it doesn't matter what the basin is, whether it's a bath basin that's holding water, a kidney or emesis basin that somebody's spitting into, a bedpan for toileting. It doesn't matter. It's only used by that one person. It is theirs and theirs alone. Good? So simply rinsing it, drying it, and storing it is perfectly okay. Think about your sink when you brush your own teeth. You don't disinfect it every time you use it. You rinse it out. And that's all we're going to do for the state exam. Rinse it, dry it, and put it away. But the process that I use to do this, basin cleaning, allows for disinfection as part of the process because there is going to be a time at some point where you will need to disinfect basins. If our patient is undergoing chemotherapy, we need to disinfect those basins before we put them away. If they have an immune disorder like HIV, we need to disinfect those basins before we put them away. If the patient has a contact isolation problem, right? They have C. diff or they have MRSA or something like that. We're going to have to disinfect that basin before we put it away. So the process of basin cleaning, this process allows for disinfection to happen by adding in one extra step. Okay? Good. So for the test, rinse, dry, store. That's it. In a clinical setting, we're going to disinfect as well. But the way we rinse, dry, store is going to be set up in a way that allows us to just add one step to disinfect. So what does that mean? So this is on page 91. When we have a basin and we have to dump it, we kind of have to think, where would it normally go? Well, if it's saliva, where do you guys brush your teeth? Over the toilet? Over the sink. So if we're working with saliva, then that would have to be disposed of in the sink. If we're working with toileting fluids like urine or feces, where does that normally go? The toilet. If you're working with bathing water, well, we didn't put soap in there. We're not putting dirty washcloths back in the basin. So the only thing that's in the basin is water. So where can water go? Sink. Good? You can. We don't put any washcloths back in the basin, any soapy washcloths back in the basin. So there's nothing in the basin but water. You can put it in the toilet if you want to. Nobody cares. Nobody cares. But it doesn't need to be. We're going to put it where it would normally go. Okay. Does that make sense? Nobody's grading you on where you're dumping it other than don't put toileting stuff in the sink. Don't do that. Other than that, nobody's grading where you put the stuff. But my rule of thumb is, where would it normally go? Just put it there. Okay. Once we dump our basin, we're going to rinse it. Now remember, for the test, we're rinsing, we're drying, and we're storing. Returning it wherever we found it, right? Rinse, dry, store. So once we've dumped it, we're going to rinse it. And then we're going to put the rinse water wherever we dumped it. So if we are working with saliva and we dump that in the sink, we're going to rinse it and the rinse water goes in the sink. But if we're working with a bedpan and we dump that in the toilet, where does the rinse water have to go? In the toilet. Okay. So remember, the basins are only used by that patient and they only need to be rinsed after every use. You don't have to disinfect for the test, but we want a process that allows us to do so. So after we rinse, we're going to set the basin down in the sink. Hands off. Because if you have to disinfect something, you can't hold it while you're disinfecting it. So we dump it, we rinse it, we dump it, and we set it down. If we're going to spray it, that's when we spray it. For the test, we're not going to spray it, though. We're going to skip that step. But now that it's clean, been disinfected, can we pick it up with our dirty hands or dirty gloves? No. So once we've disinfected it, then we're going to use a paper towel. We don't want to touch it with our dirty glove. We're going to use a paper towel to pick it up. Then we'll use a paper towel to dry the inside, a different paper towel to dry the outside, because we didn't disinfect the outside. And then one more to pick up our supplies and open the drawer. You don't want to touch those drawers with dirty hands or dirty gloves. Because remember, at the beginning of the next skill, you're going to touch the drawer with clean hands. So you have to have a paper towel to put your supplies away. So basic cleaning, dump it, rinse it, dump it, set it down. Paper towel to pick it up, paper towel to dry the inside, throw it away. Paper towel to dry the outside, throw it away. One more paper towel to get your supplies and open the drawer. So a lot of steps here. You're going to see it done a lot. This is not the last time you will see basin cleaning. Basin cleaning, I think we have like 7 skills or 8 skills with basin cleaning. So it's something you're going to see quite often. If you don't get it right now, it's okay. All right? You'll get it as we go. At the end of this step, we'll throw all the paper towels away. So you're going to see basin cleaning done in a lot of skills. Don't worry if you don't get it. Everything is cleaned the same way. So these are our steps. So now let's move on to learning hand and nail care. Which is on page 117. All right. So on page 117 at the top of the page, you'll see your care plan. It says provide hand and nail care to one hand. You're washing a hand, rinsing a hand, drying a hand, lotioning a hand, cleaning under the nails, and filing the rough edges. That's pretty much it. So we want to soak the hand in water first. That's our first step, is to soak the hand. For the test, we don't have to soak for any specific amount of time. Nobody cares. Nobody's counting. There's no timing requirement. Just put the hand in the water. But the whole point is to loosen up any debris that might be under the nails. So in a clinical setting, let them soak for a bit. It makes your job way easier. Once we have soaked the hand in water, we're going to take it out of the basin and put it on a towel. Now that's important. You don't just want, remember, they don't have that layer of fat, right? That layer of fat is a cushion, a protection. So you don't want to just lay the hand on the table. We want something soft under it. So we're going to lay it on the towel. And then we're going to get a washcloth, wring it out really well, and put soap on the washcloth, not the water, on the washcloth, and that's how we wash. So we wring our washcloths out really well, no drippy wet washcloths, put some soap on it, and we're going to wash the hand. We're going to put it back in the basin to rinse. Take it back out to dry. Okay? So in the basin to soak, out to wash. In to rinse, out to dry. Then, once we have it washed, rinsed, and dried, we're going to take one of these orange sticks, the slanted end or beveled end of the orange stick, and we're going to take it underneath the nail and kind of scoop it around to get any debris out. But I don't want to take debris from this nail and put it onto this one, so I'm going to clean under the nail and then wipe it on my towel. Move on to the next nail. Clean under the nail, wipe it on the towel. Next nail. Clean under the nail, wipe it on the towel. Next nail. So on. So it's important to understand why we're doing this. If our patient can go to the sink and wash their own hands, that is way better than doing this. Because you got running water. Can help move everything along. This is going to be done when your patients can't wash their own hands, or if they're unable to take care of their own grooming. So, how many of you guys like go to a nail salon? Anybody go to a nail salon? Anybody? Okay. When you go to a nail salon, if your nails are too long, they tend to cut them down to a specific length. If you've got kids, you probably use nail clippers on kids and cut their nails down to a specific length. But it's really, really easy when you're doing this on other people to cut the skin right next to the nail. It's really easy to do. And if you've ever gone to a nail salon, you've probably had that done to you at least once because it happens. So as CNAs, we don't use nail cutters. Those are advanced pieces of medical machinery we're not allowed to touch. Instead, we file the nails on a regular basis, and that keeps them short. Regular filing, like twice a week, you'll never have to cut nails ever. So when we're doing hand and nail care, it's either because we're trying to keep the nails at a normal length and not have to cut them, or because our patient can't get to the sink to wash their hands appropriately. Those are the two reasons we're doing this skill. If your patient can get to the sink and takes care of their own nails, you are not doing hand and nail care. Patient does it. Remember that CNAs only do for patients what they cannot do for themselves. So I think it's important that you understand why we're doing this. So hand in the basin to soak, out on the towel to wash. Hand in the basin to rinse, out on the towel to dry. Take the orange stick, clean under each nail, wiping it off before you go to the next nail. Then we're going to take an emery board, one of these things. We call them nail files. And we're going to file the rough edges of the nails. But when you file on, do I have one in here? Yes. When you file on an older person, we don't do what we do with younger. So if I take this nail file and I'm going to file my own nails, I would take it and kind of go back and forth really fast along the surface of the nail. That's what we all do. That's how we file nails. But as we age, nails become brittle. And those nails, because they're brittle, will split right up the middle. In fact, I've got one. This nail is actually doing that. I don't know if you can see it, but there is a line running right up, a white line running right up. That is a split. I have a split nail. So if you take this emery board and you go across back and forth, what that does is it pulls the nail and pushes the nail and pulls the nail and pushes the nail. And the point in the middle where those two pulls and pushes meet is what splits. Does that make sense? So when we are working with older individuals, we do not file like this in a seesaw pattern. We file in one direction only toward the center. And then right across the center. One direction only. Good? Make sense?
Then we're going to warm the lotion up in our hands, put the lotion on, wipe off any excess. That's the whole skill. That's it. So knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to do hand and nail care. Is that okay? Close curtain, wash hands, get a barrier, get supplies, put them on the barrier, get my basin, take it over to the sink, turn the faucet on with a paper towel, check the water with the inside of my wrist. It should feel warm. Put water in the basin, bring it over. Who else has to check it? The patient. Have them put their hand in the basin, take it out, put it on the towel to wash. I'm going to wring that washcloth out and apply soap to the washcloth. Wash all surfaces. Put it back in to rinse. Take it out to dry. Clean under the nails with the orange stick, beveled end, wiping off in between each nail. File the rough edges toward the center in one direction. Warm lotion up, apply it, wipe off the excess, clean everything up, rinse, dry, and store in my basin, and do my closing. Thank you very much, Miss Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine? Your environment is clean. Open your curtain. Go wash my hands. Think about the steps of my skill. Read the care plan again just to make sure. And then tell the evaluator my skill is done. Good?
You take your hand out and let it dry, or you let it dry with a towel, or you let it...
You're gonna dry it with a towel. The towel that you actually had them their hand on. Okay, so I'm going to show you this skill. I'm going to show you the video for this skill because it's got good close-ups. All right. Any questions? Okay. Okay, so another question here. Are all the skills on a live patient, or will some skills be done on the mannequins? Yeah, some skills will be on the mannequins. It's actually in my book at the bottom of each skill page. You'll see whether it's going to be done on a live patient or a mannequin. All right, here we go. Why is this not?
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm doing great. How about you?
Wonderful. I need to do hand and nail care on one hand. Is that okay?
Yes.
I'm going to close your curtain for privacy. Let me go wash my hands, and then I'll gather my supplies.
Okay.
Okay, we're going to start with the barrier. So I'll place a barrier on the table, and that will give me a place to set your clean supplies. And then I'm going to gather a basin, soap, and lotion. An orange stick and emery board. Two washcloths and a towel. I'm going to go get some water in the basin.
Okay.
Okay, Mr. Jones, would you like to check the water temperature, make
Yes,
sure it's
ma'am.
okay?
It's
Is
great.
it good?
Yes.
Okay, you can submerge your hand in there if you'd like,
Okay.
and I'll bring that tray a little bit closer to you.
Thank you.
Is that comfortable?
Yeah.
I'm going to place the washcloths in here, and we'll wet one of the washcloths and use it to get your hand wet. Now I'm going to place your hand over here on the towel. Apply soap to the washcloth. And now I'm going to wash all surfaces of your hand, including in between the fingers, in this area between the thumb and the forefinger. You're going to turn your hand over now and wash the palm of your hand. Now we're going to place your hand back in the basin to rinse. Okay, I'm going to bring your hand over here to dry. I'm going to dry between the fingers. And then I'm going to turn your hand over and dry the palm of the hand as well. Okay. Now we'll take the orange stick and I'm going to clean under each nail. Just cleaning the edge. Does that hurt?
No.
Very good. We'll wipe the orange stick on the towel in between each finger. And now I'm going to file any rough edges. So I'll file from the outer edge to the middle, checking each nail for any rough edges. And now we can apply lotion. So I'll get a little lotion, warm it up in my hands, and apply it to all surfaces of your hand. Does that feel good?
Yes.
Very good. Okay. Now we'll wipe off the lotion. Okay. How's that?
Great.
Wonderful. I'm going to place my soiled linens in dirty linen container and then clean up my workspace. I'll be right back.
Okay.
Okay, on the way, we'll pick up the soap and the lotion and place them in the basin. We'll use the paper towel to open the drawer, place the basin in. These items will get thrown away. Okay, Mr. Jones, are you comfortable?
Yes, ma'am.
Can I offer you a magazine?
No, ma'am.
Is there anything else I can get for you while I'm here?
No, thank you.
Okay, your call light is right there. Please use it to call me if you have a need. I'm going to open your curtain and wash my hands. After washing my hands, I'll review the steps of my skill, make any corrections, and then tell the evaluator my skill is done.
All right. Any questions on that?
Would you be wearing gloves with that? Would you be wearing gloves?
So the answer to that is going to depend on the patient. So if the patient has no open wounds and no body fluids, then no, we don't need gloves because we're going to wash our hands before and wash our hands after. So for this particular demonstration, my patient's skin was intact. I didn't need gloves. If my patient had a huge scar or incision on their hand, then yes, gloves would be required. Okay.
Do we have to leave the table in front of him?
You can, yeah. Yeah, that's fine. Remember that these skills that you're demonstrating are basically a snapshot out of their day. So it's not, their day doesn't end at the end of the skill. So they're sitting at the table. We can leave them there. Maybe they're going to have lunch or do a crossword puzzle or something. That's perfectly okay.
Do you want to offer to move them to the bed if they ask, like, hey, can I move to the bed? Should I be like, I'll go ask the nurse kind of thing?
So for the test, I'm going to answer this in two ways. Okay. For the test, when you are the patient, because remember, this is going to be done on a live person, you will be a patient. If you are the patient, you are going to get a script to follow. So for the test, nobody's going to ask you to move back to the bed because it's not on the script. Does that make sense? And you're not allowed to ad lib because that's a whole nother skill that's not on your care plan. Does that make sense? So for the test, that won't come up. But in a clinical setting, if your patient's like, okay, thanks for doing my hand, can I go back to bed? I really want to lay down. Well, it's going to depend on what the activity is on that care plan for that patient. So if they are, if the care plan says must remain upright until 9 a.m. and it's 8:30 a.m., can they go back to bed? No. And you would say, I'm sorry, the care plan says you need to stay up until 9. Incidentally, a lot of people don't know this. There are a couple of medications that we give where the patient must remain in a sitting position for at least an hour after the medication is given, because otherwise it causes esophageal ulcers. So our care plan would say that, must remain in a sitting position until at least 9 a.m. Does that make sense? If activity is ad lib means whatever they want as requested. So if their activity level is ad lib and they ask, can I go back to bed? Sure, help them back to bed. So it depends on the needs of that particular patient. And how do we know what to do with each patient? The care plan. Good?
Is it normal just to wash one hand? Is that what our like open? Like, that weird?
So for the test, where do those evaluators want to be? At home in their pool, drinking their Mai Tais, right? If they watch you wash one hand, rinse one hand, dry one hand, file one hand, clean one hand, lotion one hand, they do not need to see it on the other hand. They know you got it. That's good.
Like in a real life setting,
In a real life setting, it's going to depend on the patient. So if I have a patient with shingles on one hand, you're not washing that hand because that's not normal. CNAs do normal. So if I've got a patient with and shingles always follows a nerve track, so it is possible to have shingles on one hand. So if they've got shingles on one hand, I'm going to ask you to wash the right hand. Leave the left hand alone. I'll take care of it. Because soap can actually irritate, can dry it out, irritate it more. So we don't want to use soap on that particular rash. If the patient has an incision on one hand, you won't be doing it. If the patient has two very healthy hands, then yeah, you're going to do hand care on both hands. If they've got really big hands, you may have to do one at a time because they got to fit in the basin. So it's going to depend on the needs of your patient. Good? Make sense? Did I lose anybody? No? All right, let's go ahead and take our break. Come back in 15 minutes. We're going to do occupied bed. I want to try to get range of motion out of the way, and then we will jump into blood pressure. Say that again?
Would you be able to help me get into that campus thing for you?
Oh, for the online course?
Yeah.
Yeah, she needs some help too. Yes, absolutely. Just remind me at the end of class.
Are those videos like that? The one you just showed us about the basin, like those on there too?
Yes.
Oh, okay.
Okay. Okay, any questions on what we've gone over so far? Go here. Okay. Christine, you said you wanted to give me chapter 1?
Oh, yeah, I got 2 wrong. I don't know
Okay,
what
thank you. 90.
90?
90. Okay, so we're going to learn to make an occupied bed now. So this means we're going to change the sheets with somebody still in the bed. This is an important skill to learn. Sometimes our patients just can't get out of bed for whatever reason. Maybe they're paralyzed, maybe they're injured, maybe they just had a surgery, maybe they're just simply too weak. Doesn't matter. We need to know how to change the sheets with them remaining in the bed. It's not a hard skill. It's actually kind of like a party trick, actually. It's kind of neat to learn. But if you're looking at this page, you can see all the principles involved along the side. Nothing new here to learn. We know skill rules. We know opening. We know barrier. We know glove rules. We know privacy blanket. We know linen rules. I'm sorry, there is one thing to learn. Scoot and roll, and we know the closing. I do have a video for this, making an occupied bed. Along the bottom, you'll see test-specific information. Somebody with your level of experience should be able to do this in 14 minutes or less. It's going to be done on a live testing student. That person will be in bed. Documentation is not required for the skill. So there is a principle we're going to learn here. And we're going to finish up linen rules as well. So remember linen rules we learned last class? Well, here we're going to fill in the last 2 steps of that. So clean rolls toward me, dirty rolls away. And don't let anything touch the floor. Those are our 2 principles that we're going to learn here. Let's start with clean rolls toward me, dirty rolls away. Okay. So when we have a sheet or a chucks or anything that's on the bed and we have a patient laying on it and it's dirty, we're going to roll the dirty toward the patient. So if I take the sheet and roll it toward the patient, it traps all the contamination on the inside. I'm only touching the bottom side or outside of the sheet. Make sense? Okay. So dirty rolls away. Now, if I take the clean sheet, I had a different color here so you can see. I'm going to roll the clean one toward me. And when I do that, I'm only touching the bottom or underside of the sheet. So clean rolls toward me, dirty rolls away. Now I'm going to take this clean sheet, the roll, and I'm going to tuck it up underneath that dirty roll. So the underside of the sheet is touching the underside of the sheet. Does that make sense? Okay. And if we do it this way, if we roll the dirty one toward the patient, roll the clean one toward us, tuck it up underneath, it's a way of changing the sheet without what we call gross contamination. The stuff from the top of this sheet getting onto the top of this sheet. But the problem is we still have the patient. So there will always be a point where clean becomes dirty just by virtue of the patient being in bed. Does that make sense? So this isn't a sterile procedure. A lot of students get mixed up. Well, can you leave the pillow on the bed? Because the pillow was on the dirty sheet and now it's on the clean sheet. Well, so was the patient. It's okay. Does that make sense? Everybody good with that? Okay. So the way that we change the bottom sheet is clean rolls toward me, dirty rolls away. Good? Good. All right. So you can see that reflected here. You'll see the blue sheet is the clean one. The white sheet is the dirty one. The dirty one rolled toward the patient. The clean one rolled toward us. We'll tuck that clean sheet underneath the dirty and then go to the other side of the patient and roll the patient the other direction and finish taking the dirty sheet out and smoothing the clean one out. We don't want anything to touch the floor, ever. So I don't care if it's a clean sheet or a dirty sheet, it does not go on the floor. Floors are not clean. They've been walked on by everybody. So we don't want our clean sheets to touch the floor because then they'll become contaminated before we put them on the bed. We also don't want to throw our dirty sheets on the floor either. And we do this at home, so it's really easy for us to make this mistake because it's what we do at home. When you take your sheets off of your bed, when you change your sheets, where do they go? On the floor. You take them off the bed, throw them on the floor. Finish changing the bed, and then you take those to the washer and throw them in the washer. It's very common for us to do that, and we don't even think twice about it, but we can't do that in a clinical setting. It's really important that we not put dirty things on the floor to make the floor any more contaminated than it already is. So in a clinical setting, we don't have hampers in the patient's room. We don't like to keep dirty items in a clean room. So if we can't put these sheets on the floor and there's no hamper in the room, what do we do with them? Where do we put them? Where do they go? So for the test, I'm going to answer this in two ways. For the test, you will have a laundry basket or a hamper like you see over there by the privacy curtain. You will have one of those two in the clinical setting for the test. Put the sheets directly in there. But in a clinical room, like when you're out working, you won't have those things in the patient's room. So in most cases, so nothing clean or dirty on the floor. In most cases, we're going to use a soiled linen bag, or we can put a chucks on the floor and put our dirty items on the chucks. So hamper for the test, or in a clinical setting if it's close, soiled linen bag in the room, or chucks on the floor. That's how we're going to handle that. Remember I said I'm going to be doing infection control questions tomorrow? This is going to be one of those. You cannot put sheets directly on the floor. In most cases, we're going to put everything dirty in a special room called the soiled utility room. This is where we keep everything dirty. So food trays that we picked up that aren't going right back to dietary for whatever reason, sheets that we removed from the bed, soiled linens after we used them on the patient. Anything dirty goes in a soiled utility room. We in medicine don't like to keep clean and dirty together. So in most clinical settings, you're going to have two rooms on your unit. One says clean utility, one says soiled utility. Super important. You never take anything clean into a soiled utility room, and you definitely don't take anything soiled into your clean utility room. So let's say that you have to change sheets and your soiled linen bags are in the soiled utility room. So you have to go into your soiled utility room to get a bag, and you have to go into your clean utility room to get sheets. You can't take the sheets into the soiled utility room. So you need to do this in two steps. Go get the bag, put it in the patient's room. Go get the sheets and put those in the patient's room. Good? Make sense? It's really important that you understand that clean things can't go into soiled rooms, soiled things can't go into clean rooms. Good? Questions? All right. So remember, we talked about this. We use it or we lose it. Don't leave things in the patient's room for use later. They are considered soiled once they're out of your sight. All right. So that was finishing up linen rules. Now we're going to move on to scoot and roll. This is a new principle. So today, this is something new we're going to learn. This messes students up, not so much now. A couple years ago, this was a much bigger deal, but the further away we get from this, the easier it is for me to teach. You're not going to have side rails in all settings. In fact, we have to have a doctor's order to use side rails. They are considered a restraint. Think about side rails for a second. The whole purpose of putting them up is to keep your patient in bed. Do you have the right to keep another adult where they don't want to be? What do you guys think? No. If I lock that door and I tell you guys you cannot leave, not allowed to leave. You are in this room. You cannot leave for any reason. That's called false imprisonment. If you put side rails up on a bed and you tell that patient you cannot get up for any reason, that is false imprisonment. They're an adult. They have every right to come and go as they please. Now, there's consequences, obviously, to every decision we make. If your patient gets up and falls, despite every effort we have to keep them safe, well, that's a consequence of their decision. We don't have the right to interfere with that in the name of safety. So this messes students up a lot. Well, wait a minute. What does that mean? That they're going to get hurt? What does that mean? So let me kind of explain this a little bit. And we're going to get into this a little bit more on, I think it's next Monday. We're going to, there's a whole lot more to this, but I'm going to simplify this today just so that you understand. When you are an adult, you earn the right to do anything you want with your body. You're accepting the consequences for that. Legal, moral, ethical, physical, whatever the case may be. You understand there are consequences to your actions, but you're free to make those choices. Make sense? At what age are you willing to give that right up? 28? 34? 56? No. You're not willing to give that right up. So why do we automatically assume our patients are going to be okay with it? So that's right. Yeah, we tend to take over when we find somebody is vulnerable, but we have to remember they still have rights. And by us taking over, it tramples their rights. So we've got to be really careful with this. It's a very fine line. But one of the main reasons that we use side rails is in the name of safety. And I just want to kind of go over this really quickly with you to show you that side rails actually do not promote safety the way you think they do. So if I have somebody who is a fall risk, they're unsteady on their feet, maybe they're a little bit dizzy, whatever the case may be, maybe they're medicated and they're unsteady on their feet. And I don't want them get up and walking around on their own because I'm afraid they're going to fall because they're unsteady on their feet for whatever reason, right? Well, if I put them in bed and put the side rails up and keep them from getting up and moving around, what does that do to their muscles? They get weaker. That's right. What do you think it does to their coordination? Yeah, it affects their coordination. That's right. Because if you don't use it, you lose it. So by me putting this patient in bed and putting the side rails up for safety, did I help them? Well, I helped them not fall. That's a good thing, right? But did I do anything to improve their safety? No. Side rails do not improve the patient's condition. They actually deteriorate the patient's condition. So much better for me to not use side rails and walk with the patient whenever they need to go anywhere. Now, how would I know the patient needs to go somewhere, like to the bathroom? So I could ask, sure. Call light. That's right. So when a call light goes off, what should I be doing?
Running to them.
Yes, answering it quickly. That's right. Because if the call light goes off and nobody's answering it, what do you think this patient's going to do? They're going to get up. That's right. Every time. Every time. So instead of using side rails to keep your patient safe, it's a much better strategy to answer the call lights promptly, to ask them before you leave the room, do you need anything? Can I help you to the bathroom before I go? To make sure all of their needs are met so they have no reason to get up on their own. Does that make sense? Walking them frequently with assistance so that their muscles don't deteriorate. These are the ways that we help keep our patients safe without causing further harm. And in healthcare, a lot of harm has been done to patients in the name of safety. Those side rails are not there to keep your patients safe, guys. The side rails are there to make your job easier. That's the simple truth of it. And if you're doing something to make your job easier that's actively hurting your patient, is it a good action? And that's why side rails are considered a restraint. Does that make sense? And the thing is, we don't actually need them. How many of you guys sleep in a bed? Anybody sleep in a bed? When did you start sleeping in a bed? Very young age. You don't remember it, right? So when you're born, you don't sleep in a bed. We sleep in a very special thing called a bassinet or crib. Yeah. And those have tall sides because we don't want you rolling over. So baby grows. Baby's in a crib. Baby grows. And at some point, about 1.5 years old, what does baby start to do? They climb. That's right. That's right. Baby at 1.5 years old, and all of their 1.5-year-old wisdom, has decided they do not want to be confined. And they get out of that crib. And no matter what you try to do, they are going to get out of that crib. Because our drive of self-determination is strong. So we take babies out of the crib. We put them in a little toddler bed close to the floor, probably put something soft on the floor. That way, if they roll out, they're falling on a blanket, not the floor. And they learn how to sleep in a bed. And you've been sleeping in a bed ever since. And when you're young, 1.5 years, 2 years old, sure, you fall out of bed now and then. But that's how we learn to sleep in a bed. So somewhere between 1.5 years and 3 years old, you develop something called spatial awareness. This means that your body is aware of the space it has around it at all times. And this develops shortly before you're 3. It's a very important skill. Very important skill. And it's the reason that you guys are able to sit in these chairs without arms and your body doesn't fall off. Spatial awareness. Now, the thing about spatial awareness is it is controlled by a very, very, very small part of the brain, very small, that is always on, even when you're sleeping. So when you go to bed at night, you don't wake up in the exact same position you went to sleep in. You toss, you turn, you stretch, you roll. You are constantly moving, but you don't fall out of bed. So how does that happen? Well, spatial awareness part of your brain is always on, even when you're sleeping. So it always knows where you are in the bed and keeps you safe within that space. Does that make sense? There's two things that affect spatial awareness: alcohol and certain medications. Have you ever gotten a medication that had a little sticker on the side that says may cause drowsiness, use caution when operating or driving machinery? Right? So that tells us that that medication affects your spatial awareness. The second thing is alcohol. This is why you can start out the night on the bar stool with no problem, but by the end of the night, that bar stool got awfully tricky to kind of balance on. Because alcohol puts that part of your brain to sleep. Good? But the thing about this is that it's not dependent on what you're familiar with or the size of the space that you have. And let me prove it to you. You sleep in your bed all night long. You don't fall out of it, but you think it's because it's your bed. You're familiar with it. You know it. You know your space. But you probably have napped on the couch. That's a much smaller space. You don't fall off of that either. Your brain knows the space you have to work with. And it's not based on the fact that you're familiar with it either, because you guys have all gone to hotels or friends' houses or other places and slept, and you didn't fall out of those beds either, no matter how small they were. You take this piece of your brain with you everywhere you go. And so does your patient. So you put a patient in a bed, their brain knows the space they have to work with. And their brain will keep them safe in that space. They don't need your side rails to keep them safe in that bed. Their brain is going to do that on its own. But remember, I said there's two things that affect that: medications and alcohol. We're not serving alcohol. So we have to worry about medications. And that's where the nurse's assessment is going to come in. And the nurse will do a head-to-toe assessment, look at medications, and see, is this patient safe? If not, then the nurse will get the order from the doctor for side rails. Notice I did not say anything about a CNA anywhere in there. CNAs do not get to make this decision, no matter how much you might want to. It's not your decision to make. Good? A lot of CNAs get this wrong. A lot. And this is the most common infraction found during nursing home. Every nursing home has to be evaluated every year by the every 2 years by the Joint Commission. This is the most common infraction. CNAs will put side rails up to keep the patients in bed. And they'll say it's in the name of safety. Do they have that right?
No.
We took it away from healthcare workers specifically. And that's because this is a legal principle. Legal. You have the right to self-determination once you're an adult, period. No one can trample on that. There's only three exceptions to that rule. One of them is permanent. The other two are temporary. Okay. If you do something wrong, illegal, and a cop arrests you, they can interfere with your right of self-determination, but it's temporary. Who do you have to go see? The judge. The judge is the only person that can make it longer term. This is why judges declare sentences. But you have to have a jury of your peers. It's not just you versus the judge, right? Because that can go sideways real quick if you got a judge on a power trip. Make sense? Okay. So I said there's three. One of them is temporary. That's the cop. One of them is permanent or longer term, and that's the judge. The third person that can interfere with your right of self-determination is a doctor, but it is also only temporary. So if a doctor decides you don't have the mental capacity to understand safety and he orders side rails, who has to make it longer term? Same system. Not the doctor, the judge. That is correct. In order to have your right of self-determination suspended, it has to go before a judge. Do you see how important this is? CNAs cannot make this decision at all. And we don't need to. We have beds that go super low to the ground, just like toddler beds. So if the patient wants to get up, just like a toddler bed. If they roll off, they're going to roll onto a mat. They can get up. They can go anywhere they want to. We have not interfered with their right of self-determination. They're free to roam. We have bed pads, which are pressure pads on the bed that when somebody gets up, the alarm goes off. So we know, hey, Julia's up roaming. Somebody should go check on her. What's that? It does beep really loud. Yeah.
Oh,
Yeah.
CNA starts searching.
Yeah. So we have a lot of ways to promote safety outside of side rails. So don't immediately go to side rails thinking that's your only option for safety. It's not. But now we have something even more unique. Hospitals are hiring, this is important for you guys, hospitals are hiring individuals to sit at the side of the bed. That way, if the patient tries to get up, that person, we call them patient safety attendants, can see what the patient needs and help them out. So the patient isn't roaming unsafely, but we haven't interfered with their rights. All of you guys are right now eligible to work as a patient safety attendant in a hospital. So those of you who want to work for a hospital, once you get your CNA, go apply for a patient safety attendant position now. Get in, let the nurse know, hey, I'm in a CNA class, and then you'll be able to transfer to a CNA position once you're certified. So it's a great way of getting into a hospital setting now. Plus, you're just sitting there at the bedside. You can study your flashcards. Okay, good.
Patient safety technician?
Attendant.
Attendant.
Yeah, patient. That's what most of them are called, patient safety attendants. All right. So you're not going to have side rails in all settings, and we don't need them. Side rails, they restrict a patient from getting out of bed, which makes them a restraint. But we don't need side rails to keep our patients safe. The patient should always be in the middle of the bed. If the patient's in the middle of the bed, guess what? They're safe. Doesn't matter if they're on their back or on their side. If they're in the middle of the bed, they are safe, right? Now, I'm going to show you something. I'm going to turn the camera, so you'll probably have to back up just a little bit. Let me show you guys something.
Oh,
All right, I need a volunteer. Somebody come lay down in this bed. This is going to be super easy. Just lay down in the bed for me. Somebody, anybody. All right, so just lay down on your back in the bed for me. All right, now he knows he's not going to be in this bed very long. I just asked him to lay down. Where did he put himself? Did I ask him to do that? Why did he do that? Wouldn't it make more sense for him to lay on the edge because he knew he's going to be getting right back up? It would make more sense for him to be on the edge. Why did he put himself in the middle? He wasn't even aware. You didn't even recognize that, did you? No. He's not even aware that he put himself. He's now trying to go, why did I do that? Yeah, why did I do that? It's because that's where his brain said he is safest. He's not even aware of it. He just did it automatically. Your patients do the same thing because guess what? They've got brains too. Okay. So can I ask you to turn roll so that you're facing that wall? Okay. I asked him to roll. Did he roll?
No.
Where is he? Ah, wait a minute. So I asked him to roll so he's facing that wall, but he shifted his body weight so he remained in the. He's not even aware he did that. He's now trying to figure out, why did I do that? Right? If he had rolled, where would he be?
More on the edge.
Yeah, on the edge. Would he feel safe there? No. So his brain thought, okay, I've got to turn. So if I'm going to turn, I've got to be in the middle of the bed where I'm safe, and scooted his bottom toward me so that he remained in the middle of the bed after the turn. Thank you very much. Great job. Don't forget your phone. So it's important that we understand that the mechanism for this is already built in. Okay, so Joe Bangles asks, what about dementia patients? Does spatial awareness change with that in age? And the answer is it can, yes. And that would be evaluated by the nurse and then reflected in the care plan. Okay, good. Does that make sense? Pretty cool, right? So if your patient is turning, they're going to do this automatically. You're not going to have to ask them. They're going to do it automatically because that's where their brain is going to direct them to keep them in the middle of the bed, just like you. When you go home tonight and you lay down, pay attention to what your body does when it turns. It's pretty neat. But if we are going to turn the patient, that's when the game changes, because we have to keep our patients safe if we're going to roll them. So if I had just rolled him onto his side, he would be very near the edge and he would feel unsafe. So that's not a good strategy. Instead of rolling him, I am going to scoot him toward me and then roll him. So when I scoot his whole body toward me, so he's like on the edge on his back, and then I roll him, he ends up in the middle of the bed on his side. Good? Guys, this is why we don't use side rails very often. This is why we have to have a doctor's order, because side rails kill lots of people every year. Because that person, just like when you're 1.5 and you're climbing out of the crib and nothing's going to keep you there no matter what we try, your patient that wants to get out of bed is going to be just as determined. They're going to go over, under, around, or through, and that's how injuries happen. And this happens way more than you would think. Side rails kill about 200 people a year. Killed a whole lot more before we got smarter about side rails. Good. This is why we need a doctor's order. Half rails are not side rails. Half rails looks like this or this right here. Those are positioning rails. Anything that leaves the bottom half of the bed open for our patient to get in and out is not a side rail. This is a positioning rail. It helps our patients move around in bed. They can grab it, but it doesn't keep our patient from getting out of bed. This does. Good? So basically, the patient needs to be in the middle of the bed, the safe zone, no matter what. They need to be in the middle of the bed at all times, especially after they've been turned on their side. So if we scoot them toward us and then turn them away from us, they end up in the middle of the bed, just like he did. Good? Make sense? Okay, we always want to turn the patient away from us, never toward us. First reason is weight distribution. Most of our weight is along our back. Gravity is always trying to pull the patient back onto their back because of weight distribution. If you put a patient on their side, gravity will pull them back onto their back. Weight distribution. So if gravity is working against us, we want to be on the same side. So if they're rolling, we're able to stop the roll. If they're rolling away from us, we're now having to reach across the patient to stop that roll. and that can cause injury to them and to us. But the other reason that you want to turn a patient away from you, there's no nice way to say this, guys. I'm sorry. But you do not want your patients to be eye level with your crotch. It's that simple. I don't care whether you're male or female. We have a patient who is a stranger laying down, which is a vulnerable position, and poorly dressed. You turn them face level with your crotch, and that is an overt threat to anybody who has been a sexual abuse survivor. Do you guys understand that? Never turn a patient toward you. Good? Okay. We talked about this bed position. We have the head of the bed, we have the foot of the bed, and we have the entire bed. So there's 3 different adjustments that we can make on a bed. Head of the bed, up and down. At the end of the skill, it's just all about patient preference. Foot of the bed, up and down. At the end of the skill, it's all patient preference. Entire bed, up and down. At the end of the skill is safety. I bring this up because we're changing an occupied bed. That's a lot of work. It's a lot of bending. So if you want to raise the bed to a comfortable working height, you can. You can raise that bed up to make it comfortable while you're changing these sheets. But at the end of the skill, what do you have to remember to do? Put it back down. And at the end of the skill, you're going to be in a hurry because your skill is finally done. And you're just trying to get to that my skill is done part. And you will forget to put the bed down. You will. That's a safety infraction on the test, and it counts really big. So if you decide to put the bed up to make it more comfortable, please take a minute to look at the patient before you end your skill. Make sure that bed is low. Good? Good. All right. So we don't want the patient to lie on a bare mattress. So clean rolls toward me, dirty rolls away. Make sure the patient is on the sheet, not on the mattress when we're doing this. We're going to replace the sheet on the bed, one side at a time. So I'm going to replace the sheet on this side, have the patient turn on their back, go around to the other side, scoot them toward me, roll them away, and then change the sheet on that side. Then we'll put a top sheet on. We want to make hospital corners, which I'm going to show you how to do. And we want to loosen the sheet over the toes so it's not bending the toes down because it's so tight. And we're going to change the pillowcase with the opening of the pillowcase facing away from the door. A lot of people walking up and down the hallway, all of them have germs. All of those germs on air currents can come in inside the pillowcase. Now, the inside of the pillowcase is warm, dark, moist. Patients drool when they sleep. Warm, dark, moist. You don't want pathogens on air currents getting into that pillowcase and having a place to thrive. Remember, these are big bad pathogens, not little bitty ones. So pillowcase facing away from the door. Don't tuck your sheets along the sides of the bed. The bottom sheet gets tucked around the mattress, but the top sheet has to be free so your patient can move around. And we want to limit the amount of time without a pillow. It's uncomfortable. So you had a question?
No, I'm stupid.
No such thing. All right. So let me show you this particular skill. I'm going to show you the video because it has really good close-ups of this skill.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Good, how are you?
Wonderful. I need to change your sheets. Is that okay?
Yes.
I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back.
Okay.
We'll start out with a barrier. going to get a top sheet, a bottom sheet, and a pillowcase, and a privacy blanket. Okay, Mr. Jones, I'm going to place this blanket over you. This will help protect your privacy and keep you warm while we do this skill, okay?
Okay.
Okay, I'm going to spread this out. Can you hold that blanket in place?
Yes.
And I'm going to remove the sheet from the bed. We'll place the sheet in dirty linen. Mr. Jones, can I get you to scoot toward me, please? Thank you. And can you roll up so that you're on your side facing in that direction? Thank you. I'll remove the two corners of the sheet from this side of the bed. And I'm going to roll the soiled sheet in toward the patient, tightly. I'm going to tuck it up underneath the patient all along the length of his body. Now I'll take the clean sheet, unfold it, spread it out on the mattress, and attach the corners. Now I'll roll the clean sheet toward me. We'll roll it so that it's tight with no wrinkles as we tuck it under the soiled sheet. Okay, Mr. Jones, come on back onto your back, and I need you to scoot to the center of the bed, please. Thank you. Can you scoot toward me, please? And can you roll so that you're laying on your side facing away from me? Thank you. I'll now remove the sheet from the bed that was soiled, wrapping it into a ball. And I'll go place this in dirty linen. Now I'll unroll the clean sheet and secure the corners on the mattress. As I do so, I'll make sure to stretch the sheet so that it's flat and minimize the wrinkles that are underneath the patient. Okay, Mr. Jones, can you come back onto your back, please? And scoot to the middle. Thank you. I'm now going to place the top sheet over you. And I'll remove that bath blanket now. We'll roll it in a ball and place it in dirty linen. Now I'm going to secure the sheet. I'm going to lift the mattress and smooth the sheet down so that it's flat under the mattress on both sides. Now I'll make hospital corners by lifting the top edge of the sheet about a foot from the end of the mattress, straight up. It'll form a triangle. Everything else will get tucked underneath. I'll repeat that on this side.
And I'll loosen this over his toes so he has some wiggle room. There, how's that, Mr. Jones?
Perfect, thank you.
Very good. I'm going to remove the pillow from under your head. I'll bring it right back. I'll remove the pillowcase, being careful not to allow it to touch my uniform, and lay the pillow on the overbed table. We'll place the pillowcase in dirty linen. I'll take the clean pillowcase and scrunch it up all the way to the edges. We'll put the tag side in, place the pillowcase on top of the tag side of the pillow, and pull the sides down. I'll now place the pillow under his head with the opening facing away from the door. How is that, Mr. Jones?
Perfect, thank you.
Are you comfortable?
Yes, ma'am.
Here's your call light. If you should need anything at all, please don't hesitate to call. Can I get you something like a magazine?
No, thank you.
Okay, I'm going to open your curtain and wash my hands. The barrier will be thrown away. After washing my hands, I'll think about the steps of my skill, make any corrections, and tell the evaluator my skill is done. Okay, question, do you need gloves for this skill? Well, it depends. If my patient has no open wounds, if they're holding on to all of their own body fluids like a champ, then there's no need for gloves. If I'm not sure what I'm going to find under the patient, then I'm going to wear gloves because there's a potential for body fluids. So it depends. This particular skill that you just saw, my patient was fully clothed in bed. Am I going to touch any body fluids or any body parts, personal skin? No. So for the test, your patient will be fully clothed. So do you need gloves? No. In a clinical setting, if you've got a patient who is incontinent, you need gloves. If you've got a patient who has an incision, you need gloves. If your patient is fully clothed and holding on to all of their body fluids, you don't need gloves. Good? It's never based on the skill. It's based on the patient. Good? Questions?
Do you have access to these videos? Like, what?
Yes.
Like, through our email?
You, they should be in your email, but you also have them in the course. So each one of these lessons, each one of these skills has a whole lesson on it in the course. Do you remember the sequencing activity that we did on the first day where we put, hand washing in order and the opening in order? You have those same sequencing activities for every skill in the course. You've got a million questions, practice questions in the course as well. So you guys all were enrolled in the course. Did you get your email that says you were enrolled? So all you have to do is go to courses.foryourcna.com, sign in, and you've got access to the whole course. Okay. Good. That's part of your enrollment in here. You have access to that. But if you just want to review the videos quickly without signing into the course or without going through the lessons, on my main website, which is foryourcna.com, on your syllabus, way down here, this fine print way down here, tells you about the course, the site to go to access the course. But it also tells you to go to foryourcna.com under the training menu. Click on skills videos, and all of these videos are there. You can also find us on YouTube as well.
All these videos?
Yep. All right, good. Questions? Okay. So we are going to go to range of motion, elbow and wrist.
go back here. This is on page 78. Now, we have not learned range of motion. We're supposed to learn range of motion shoulder. On Wednesday, we didn't get to. We're going to do range of motion elbow and wrist now. So I'm going to teach you what we missed on Wednesday. So if you look at this, there's nothing new here to learn. We know skill rules, we know the opening, we know glove rules, and we know the closing. So we just want to focus on skills specific. So the care plan for this is on page 79. At the top of page 79, you see, provide the following range of motion exercise to the resident's right elbow and right wrist. Flexion, extension. Provide 3 repetitions of each exercise, and the resident is not able to help with the exercises. So what is this? What does it mean? What do we need to know? So range of motion is a series of exercises that CNAs do to retain function. Physical therapy does exercises to regain function, bring something back, make it better, improve it. That's not us. Physical therapists have to have a doctorate degree. That's 11 to 12 years of education. How long are we here? 4 weeks. That's not us. Not us. We do not say things like no pain, no gain. Not us. We don't do pain at all. So if we're doing range of motion on the elbow and we get up to here and the patient says, ow, the next one will go below the ow. We don't keep going. We don't do ow. We go below the ow and then we let a nurse know, hey, there was an ow, and let them figure it out. Not our job. Got it? Okay. So it's super important that we understand our role here. CNAs retain function, what's already there. We're not trying to make it better. We're just trying to keep it from getting worse. So let me give you an example of this really quickly. We have a patient who tore his right rotator cuff playing tennis with his brother. Ow. Has surgery. Ow. Has to go to rehab. Ow. But during that time, the 6 weeks he's in rehab, nobody's paying attention to his left arm because that's not the one that's hurting. Everybody's worried about the right shoulder. So in that time, at the end of 6 weeks, he gets discharged home. His right arm is great, back to normal. His left arm has not moved in 6 weeks. What do you think it's going to be like? Stiff, sore, limited range of motion. We fixed his right arm and broke his left. That's what we did. Did we really help him? No. So let's rewind. While he's in therapy, CNAs are instructed to do range of motion on the left arm because physical therapy is focused on the right. Does that make sense? Do you guys understand why we're doing this? We're simply trying to keep the level of function he already has. We're not trying to improve anything here. So CNAs do exercises to retain function. Good? So if we read this care plan, by the following range of motion exercise to the resident's right hip, knee, and ankle. Oh, this is the wrong one. We're going to follow the care plan. This is supposed to be elbow and wrist. Sorry, I got the wrong care plan up there. But right elbow and wrist, flexion, extension, provide 3 repetitions of each exercise. So remember, the care plan is going to tell us what body part, what exercises, and how many repetitions. So now let's look at the exercises. CNAs do 3 exercises. That's it. That's all we do, 3. We have flexion extension, which is up, down. It would look something like this. Up, down. Okay. Up, down. Flexion extension is up, down. Abduction, adduction is a side-to-side motion. So if you abduct a child, you take away from its family. Don't do that. That's bad. Okay. But if we abduct an extremity, we're going to take it away from its family, side to side. Now, watch my hand here real quick. Watch where my hand ends up. Flexion, extension. See where my hand is? Abduction, adduction. See where my hand is? My hand ends up in the same place, but they're working different muscles. Okay. This way, my palm is facing forward. This way, my palm is facing to the side. That's why it's a side to side motion. And then you have around. Around just means around. Rotation. I'm sorry, you have rotation. Rotation just means around. Okay, so my wrist can go around. My elbow cannot. The elbow only works in one direction. If you get an elbow to do anything other than this, you broke it. This is all, it's a hinge joint, guys. It's all it does is go up and down. So your care plan is just going to have you do up and down on the elbow because it can't move in any other direction without breaking it. But the wrist can move in all directions. It's an articulating joint. It can go up and down, but it can also go side to side and it can go around. So I need to follow the care plan. Got it? Got it? We always support an extremity from below. Always lift from below, supporting at the joints. Always, always, always. We're going to move slowly and smoothly. We'll return to the start position. And we want to monitor for any discomfort. So we're going to ask, does this feel okay? Are you having any pain? Watch their face for grimacing, wincing, signs of pain. Remember, we don't do pain. We'll do our opening. Oh, thank you. We'll do our opening. We'll do the skill. And of course, we always end with the closing as well. Now, for this skill, your patient is fully clothed, holding on to all of their own body fluids like a champ. Do we need gloves? No. No. If the patient had an incision on that arm, would we need gloves? Yes. All right. So we support the extremity near the joints. We lift from below with a flat palm. We move slowly and smoothly. We return all the way to the start position. Flexion extension is up and down. Abduction, adduction is side to side. Rotation is around. And we're going to ask about pain. So if I can get somebody, no, two, I need two. Somebody to come over here and lay in this bed for me. Actually, I'll just pick on you. Come on over here. Come lay in bed for me. So my care plan for this skill told me, can somebody read the care plan to me? Is it right elbow and wrist? Okay. Go ahead and lay in that bed for me. Yeah, you got company in that one. All right, so I'm going to do this skill from beginning to end with hand washing. Okay, so just like it would be done for the state exam. Good? So if I can ask you to do me a favor. I'm going to ask you to go sit in my chair up front. And when I go to the sink, you see that row right here in front of you? See where it's got red? Number 2 is red. When I go to the sink, can you hit number 3? And then when I leave the sink, go back to 2. Okay? Everybody good? Ready? Here we go. Hi, Miss Jones.
Hi.
My name is Patty. I'm your CNA today. How are you?
Good, and you?
Fantastic. I need to do some exercises on your right elbow and wrist. Is that okay?
Yep.
All right. I'm going to close your curtain. Let me go wash my hands. That is not closing. There we go. Let me go wash my hands and I'll be right back. So my opening is done. I'm going to come over here, turn the water on, wet my hands, and I'm going to get lots of soap because I'm graded on bubbles. When I bring my hands together, I'm going to look at the clock and start timing. I'm going to wash the tops of my wrists, the backs of my hands, in between my thumb and index finger, the bottom of my hand by my pinky, the palm of my hand in between. So all surfaces for at least 20 seconds, and that is 20 seconds. Now I'm going to move on to my nails. I'm going to take my thumb, go down each one of my nails, circle my nails on the palm of my hand, and then rinse. When I rinse, I don't want to touch the sink or the faucet. After rinsing, I'm going to tap, keep the water in the sink, I'm going to get some paper towels to dry only what's clean. We'll throw those paper towels away. Get clean, dry paper towel. Turn the faucet off. All right, Miss Jones. I'm going to do all the work. All you have to do is let me know if there's any pain or discomfort as we do this, okay? First thing I'm going to do is bend your arm up and back down to the bed like you're making a muscle. So we'll turn your palm up. We're going to go up like you're making a muscle and back down. Feel okay? Any pain?
Nope.
Up, all the way back down, and one more. Up, all the way back down. Notice I'm going all the way to start. Now we're going to move on to the wrist. I'm going to have you make a loose fist, and we're going to go forward and back like you're revving a motorcycle. You should feel a little stretch. Let me know if there's any pain. Forward and back. Feel the stretch?
Yep.
Forward and back. Good. One more. Forward and back. Okay? Any pain?
Nope.
Are you comfortable?
Yep.
Is there anything else I can get for you while I'm here?
Just the lights off.
Okay. All right. Would you like them? Well, if you're getting the lights off, you don't want a magazine. There's your call light if you need anything at all. The environment is clean. She is covered by clothing, so I don't need to worry about a sheet. I'm going to open the privacy curtain and then look around, make sure there's nothing else I need to do here. I'm going to go wash my hands. So we'll turn the faucet on, wet our hands, get some soap, bring them together, look at the clock. We're going to rub around the tops of the wrists, the backs of the hands, in between the fingers, in between the thumb and index finger, the bottom of our hand by our pinky, and the palm of our hand, interlacing those fingers. And that is 20 seconds. So I'm going to go down each one of my nails with my thumb to clean my cuticles, circle my nails on the palm of my hand to clean underneath, and then rinse. Being careful not to touch the faucet or the inside of the sink. We're going to tap to keep the water confined into the sink, and then get some paper towels to dry. Nobody cares how many. Get 2, get 10, nobody cares. We're going to dry what's clean. Throw those away. Clean, dry paper towel to turn the faucet off. I'll read that care plan one more time, make any corrections I need to make, and then tell the evaluator my skill is done. Thank you. Good job. All right. So Bunja, that was the last. Yeah. We only need gloves if we're going to touch body fluids or personal skin. All right. Any questions on any of that?
You said she was fully clothed, so she didn't have to worry about a sheet. It was like they wanted a sheet.
Yeah, if they want a sheet, that's fine. That's preference. Yeah, whatever they want.
You don't have to like say anything about it.
Don't have to address it.
In the test, you don't have to bring that up.
No. The test just wants them to be covered in some way. No knobby knees. Remember that. You cannot, no knobby knees, right? You can't see their knees. So if they're in, if you're working with a mannequin and she's in a gown, you've got to make sure she's covered, right? That's a privacy issue, a patient rights issue. But when you're working with live patients, they're always dressed for the
But
test.
we don't have to acknowledge.
Don't have to acknowledge it. No.
Now, as you say like no knobby knees. Now what if they are like wearing shorts? Is that like
Oh, that's a good point. Yeah, I shouldn't use the knobby knees, huh? If I would probably cover them.
if they're wearing shorts?
Yeah, I probably would. Yep. Yep. All right. Let's see here. Jamangles says, I get a little confused with the charting and washing hands again. Would you wash, chart, then wash again? Yes, that's exactly right, Jamangles. Absolutely. You wash your hands and then you pick up your pen, because remember, your pen goes home with you at the end of the day. So you would pick up your pen and document, and then you have to wash your hands again because of the documentation form. Okay, or the keyboard if you're doing electronic. You have to wash your hands again. You always end skill with clean hands. That's the very last thing you do.
If there's
Care plan. Whatever the care plan tells us. For the test, the care plan will tell you 3. Okay, good? Questions? No? All right. Let's go to page 56. Blood pressure is not tested on the state exam. You are not going to have to perform blood pressure. Not a manual one, not an electronic one, no blood pressure skill on the state exam. But that doesn't mean that you won't find it on the written test. So you do need to know your normal blood pressure values for the written test. And you do need to know the procedure. If we are taking a blood pressure with an electronic cuff and we get an abnormal reading, what do you think we need to do? Yeah, double check it with a manual. Take it again manually because it could be a machine problem, not a patient problem. And that's the only way we're going to know. Yeah, there's a problem, but is it a machine problem, like the machine is malfunctioning? Or does our patient have high blood pressure? So if we get an abnormal reading, we always double check it manually. And that's why we have to learn to do this. Okay. Blood pressure is a complex skill, but it is not tested on Prometric's skill test. Other states still test it though. So we get off easy. All right. So let's explain what a blood pressure is. So in your chest, you've got a heart. I got to stand up. Okay, in your chest, you've got a heart. That heart squeezes and it pushes out a wave of blood. That wave pushes the one in front of it. That wave pushes the one in front of it, and so on. And this is how blood moves through your circulatory system. Okay? Yeah. That could have been bad. This is how blood moves through your circulatory system. So normal for a systolic or top number is between 100 and 119. Normal diastolic is between 60 and 79. These are your normals. You need to know these. They're on the first column of page 57. You'll see your normals. But you do need to know this. So how do we take a blood pressure? So what we're going to do is inflate the cuff up to somewhere between 160 and 180. That's as far as CNAs go, because CNAs do anything over 180, not normal, not in any realm. So who would have to do that one? The nurse, not our problem. So as CNAs, we go up to somewhere between 160 and 180 by inflating our cuff. When we get up to somewhere in here, we're going to slowly deflate the cuff. Now, you are in control of the speed that this cuff deflates. I'll go over that in a minute. You're in control of the speed. If it goes too fast, if your needle goes, woo, that's too fast. You're not going to get the numbers. You're in control of that. So if you say, oh my gosh, the needle went too fast, that was you. Okay, so we inflate up somewhere between 160 and 180, and then we slowly deflate so our needle comes down like this. It should kind of look like a second hand going backwards. And it should never stop. Never stop. If it stops, that's you. Keep going, 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 keep going. And you can stop there at 0. Okay, good. So what are we doing when that cuff is inflating? So we inflate the cuff up to somewhere between 160 and 180. We deflate and we're going to listen. Now what we're looking for are thumps. They sound like thumps. Okay, that's what we're listening for is a thump. But we want to hear the first thump and the last thump. So let's think about first. What does first mean? What does that word first mean? Number 1. So what comes before first? Nothing. Right? If I'm telling you I'm going to give you your first ticket, how many tickets have you ever gotten? None, right? So nothing comes before the first. Does that make sense? Everybody with me? Okay. So when we inflate this needle up to somewhere between 160 and 180 and we start to listen, there's going to be nothing there because we're listening for the first. Does that make sense? So as that needle comes down, it's going to be quiet, 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 still quiet, nothing happening, quiet. And then you'll hear a thump. Now, where the needle is, when you hear that first thump, whatever number that needle is pointing to, that's your top number. Well, if the first thump got through, the rest of the thumps can get through. So we're going to hear more thumps. So first, and then second, third, fourth, fifth. So thump, 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 thump. They get lower in volume as they go down. So thump, 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 thump. And then eventually you're going to hear no more thumps. So we want to pay attention to where we hear our last clear thump, and that's your bottom number. And then you'll hear nothing after that all the way to 0. So we inflate. It's quiet. We listen for our first thump. We'll hear more thumps we don't care about. We're listening for the last thump. And then it'll be quiet again. Where we heard the first thump and where we hear the last thump is the blood pressure. Those are the two numbers of the blood pressure. Good? So easy. Easy. Except that there's a lot going on here because your hand has to control that valve. Remember I said if it goes too fast, it's you. If it stops, it's you. So your hand has to control the air coming out. Your ears have to listen for that thump. Your eyes have to see where the needle is when the thump occurs. And your brain has to figure out what number that line represents. So there are 4 things going on when you're taking a blood pressure. And it takes a while to learn it. It takes you about 45 blood pressures before you really start to understand what's happening here. 45. You are not going to be accurate today. Okay? That means you got a lot of practicing to do to get this down. Good? Good? Okay. So we have 2 pieces of equipment we're going to use to take a blood pressure. We have a blood pressure cuff and a stethoscope. So go ahead and pull yours out. Sure. So first we'll talk about the blood pressure cuff. So blood pressure cuffs look like this, like what you see up here. Go ahead. Okay. So some of you have professional cuffs, some of you have home cuffs. If you have a metal bar on your cuff, that is a home cuff. I will talk to you guys in just a moment. Don't undo the metal bar. Leave it just how it is. Yours is a professional. You're good. See hers? See how she has a metal bar? Okay. So some of you have personal cuffs. Some have professional cuffs. So you have a gauge. Those of you with professional cuffs, you have a gauge. The gauge has a clip on the back. If you push down on the bottom of the clip, the top magically opens. On the front of your cuff, you have a tab, a fabric tab. Open your gauge and slide it up that fabric tab so it is attached. If you have a metal bar, you probably do not have a fabric tab. Okay, so metal bar people, just hold up. I got to do this in 2 sections. Professional people, make sure your gauge is attached, because if this falls off, your patient's wrist is right there. This gauge is heavy. If it hits a wrist with osteoporosis, it will shatter it. It will shatter it. Okay, good. All right, so those of you with metal bars, you do not, most likely do not have a fabric tab, because your metal, the cuff that you have is designed to take your own blood pressure, not somebody else's. So that metal bar helps you tighten up that cuff around your own arm. So it's set up differently. For some of you, your blood pressure or your stethoscope is actually attached physically to that. Again, this is to take your own blood pressure, not somebody else's. So you can still use it to practice, but it's not optimal. You'll have some differences. Okay, good. All right, so on this cuff, for professional cuffs, you will have a white stripe. Looks like this along one edge. This is called an index line, or it tells us if this cuff is going to fit our patient. If I'm concerned that this cuff is too big for my patient or too small, can you come here? Yep. Yep. So if I'm concerned, if I don't know whether this cuff is going to fit this patient, I'm going to take the cuff, put it about 1 inch above the elbow, wrap it around the back of the arm. If I can see both edges, it's fine. If it wraps more than halfway around her arm, it's too big. If I can't see either corner, it's too small. Okay? So this is how we measure to see, will this work on our patient? Good? Good? Okay. You also have an artery marking. Don't get ahead of me, guys. Don't get ahead of me. You also have an artery marking here. This cuff has no brain. It cannot tell you where the artery is. You are going to use this to tell the cuff where the artery is. So in order to do that, we have to find the artery. So if you hold your arms out, one arm, get that elbow popped up. No lazy elbows. Get that elbow popped all the way up. 2 fingers. Remember, we do not use our thumb to find a pulse. 2 fingers at the lines. Remember, lines are important. At the lines, but this time, instead of being on the thumb side, we're going to be on the pinky side. So we're going to come straight up from our pinky at the lines, 2 fingers. See if you can find your thumps. Put your thumb on the back. Use your fingertips. Get that elbow popped out. Get the elbow popped out. It's not in the middle, guys. It's on the inside. See if you can find your thumps. Everybody find your thumps? You can't find your thumps? Okay. Are you dead? I can practice CPR. So it's going to be right here. Right there.
Yeah, I can't find mine's kind of like weak.
Let's see here. Yeah, yours is, it's right there, but it is faint. You get a lot of muscle there. Find it? Good? Good? Everybody find it? No? Okay. Keep your fingers here, because I'm going to show you something. So I want to get that arm straight up. Don't let it relax. Right there.
Oh.
All right. With your finger over the artery. So you got your arm out, you got the artery. With your finger over the artery, relax that elbow. What happened to your thumps? They don't, yeah, they went away. Bring your arm back out. It pops that artery closer to the surface so you can actually feel it. This is why I keep saying no lazy elbows. You got to get that arm completely straight in order to feel it. So when you go home tonight and you're practicing on your loved ones at home and they do this, you're not going to feel the artery. You got to get that arm completely straight to pop that artery up so that you can feel it. Okay? Good? Okay. You're not going to hear it. Take that out. Yeah, for 3 reasons, actually, you're not going to hear it. So don't get ahead of me. You need to feel it, not hear it. You're not going to hear anything with your stethoscope because you don't have any pressure on there. Remember, we inflate, it's quiet, quiet, quiet. We have thumps and then it's quiet again, right? When there's no pressure, it's quiet. You can't hear it. It has to be under pressure to hear. Okay? All right, so we want to feel it. Now, we can take our blood pressure cuffs. Don't do this. I'm just going to show you. We can take our blood pressure cuffs, lay it on the arm where we feel that thump, and now we can move this arrow, and I now know exactly where to put my stethoscope. Okay, so that's what this is for. You lay the cuff on, you find the artery, and then you line that line up with the artery, and you secure your cuff, and now you know where to put the stethoscope. So why is that important? We're going to use this bulb and valve to inflate the cuff and deflate the cuff. I'm going to show you how to do that in just a second. Well, let me show you now because my slide tells me to show you now. Okay, so this bulb and valve assembly, you're going to hold it in your dominant hand. So if you're right-handed, you hold it in your right hand. And you hold it so that the tubing comes up, not like this. You hold it so the tubing comes up and that dial faces you. Okay, so tubing comes up and dial faces me. So it will look, where is it? So it'll look like this, okay? So tubing facing up, dial facing me. Righty-tighty. So if I turn this to the right, don't tighten it, just turn it till it stops. That's how we're going to put air in. And then when it's time to let the air out, we're going to turn it ever so slightly to the left. Now, look really close at how far I'm moving this. Do you guys see?
Just a tiny, tiny bit.
Oh my gosh, like a hair, right? And that's too much. So when you're letting air out, it is the tiniest of motions. When you open this, it is the tiniest of motion. Remember I said that you are in charge of how fast that needle goes? Have you ever had your blood pressure taken and they pump it up and it goes, woo, and then they give you a number? Yeah, they lied. They did. They lied. They lied. I'm going to prove it to you. There's a lot of people out there lying about blood pressures. There's a lot of people out there lying about blood pressures. So we're going to turn it to the right to close it, turn it to the left to open it. Remember, we're inflating somewhere between 160 and 180. So when we get to that point, when our needle gets to that point, we're going to stop squeezing. Then, let me show you what's happening on the inside of the body. So we have a cuff around the arm. I've cut this away so you can actually see the artery. When we inflate the cuff, it's going to push in. Okay, the cuff is designed so when we inflate it with air, it pushes in. And that takes these muscles and it crimps the artery closed. That's what we're doing in here. We're using the cuff to push in on the muscles to close off that artery. That's why it hurts. That's right. So then we're going to slowly open that up. But in the meantime, the heart is still beating over here. We didn't stop the heart. We just closed the artery. We closed the road. So the heart is still beating and still pushing out waves. And those waves are just backing up waiting to get through. Everybody good? Okay. So as we turn the dial counterclockwise to the left, and we let some of that air out and that needle starts to come down, inside here, what happens is as that pressure starts to dissipate, right, and the muscles are able to spread open a little bit more, it gives us a gap here. And that wave of blood is going to start moving through that gap. It's a small gap. It's a tiny gap. As that wave of blood moves through, the other ones behind it can also move through. So as that wave of blood moves through, because it's such a small artery, we've really compressed it. We are going to be listening with our stethoscope over that artery. And as it moves past, because the artery is so small, it hits the top of the artery and makes a thunk sound. And that's what we're listening for. Good? Does that make sense? Well, if we heard one thunk, we know we're going to hear more because they're just following the leader. More thunks, more thunks, more thunks, more thunks. And then eventually, so the first thunk that we hear, wherever that needle is, that's our top number. As more thunks go through, we don't care about those. We're going to get to a point where the artery is wide open now. See how these waves aren't hitting the top of the artery anymore? What do you think is going to happen to our sound? Goes away. So now we're listening for the last thunk that we hear. And where the needle is, when we hear that last clear thunk, is our bottom number. Good? Okay, so we're squeezing the artery closed. We're opening the artery little by little. Waves are going to start going through. We're going to hear the first one. That's our top number. We're going to hear the last one. That's our bottom number. We want to make sure that we get all the way to 0, though, because we're still compressing this arm, and that still hurts. So go all the way to 0. So this person's blood pressure was 118. That's where we heard the first thunk, over 78, which is where we heard the last thunk. And congratulations, you just took your first blood pressure. Okay. We're going to keep deflating until the needle hits 0. And now we can remove our cuff and record our reading. So the number where we hear the first thunk is our top number. So we're going to learn how to read this dial in just a second, but this is 100, 102, 4, 6, 108. And then where we heard the last thunk, this is 60, that's 70, 72, 74, 76, 78. So this person's blood pressure is 108 over 78. So now we need to learn how to read this dial. So when you're looking at the dial, you'll see the 20s are marked. So 20, 40, 60, 80, 100, 120, 140, 160, 180, 200, so on. The lines in between, the big lines are 10s. So if this is 20, that's 30, 40, 50, 60, 70, 80, 90. The little marks are 2s. So if this is 140, that's 142, 144, 146, 148, 150. What makes this tricky is that needle is going to be going backwards. So you kind of have to adjust your thinking here. If our needle is here, it's not 102. It's 98. Got it? Got it? Okay. So we're going to recap. We're going to inflate to 160 to 180. Deflate slowly. Listen for the first thunk. That's your top number. Listen for the last clear thunk. That's your bottom number. Deflate to 0 and then document. Good? All right. So now let's learn about our stethoscopes. Stethoscopes are more complex than the blood pressure cuff.
Wait, can we learn how to wrap this thing back up?
Yeah, 1 second. 1 second. You're going to need it in a minute, so don't wrap it up yet. All right, so let's talk about stethoscopes. this is the head of a stethoscope. These are the ear tips. The head of the stethoscope, don't put them in yet. Stay with me, guys, because everybody's doing it wrong. I'm going to show you in a minute, and it'll confuse you. So I need you to stay with me. So this is the head of the stethoscope. We are going to be listening to a wave of blood moving through an artery buried under skin, fat, and muscle. This is not a big sound. We need a big microphone. So we are going to use the large diaphragm on our stethoscope. This has 2 diaphragms, though. We have one on this side and we have one on this side. These are not both active. This is a microphone. We do not want both sides active, just the one we're listening to. So this whole thing turns. Okay. Now, those of you who have double tube stethoscopes like mine, just below, you'll have a flat bar with a circle. Those of you who have single tube stethoscopes, you will probably see a little dot. Look for your dot. Everybody have a dot? Okay, your large diaphragm needs to be facing the same direction as your dot. The dot is your on side. When you go to put this back in your bag later, chances are it's going to flip over on you. So when you get it out later tonight to practice, make sure your large diaphragm is facing the direction of your dot. Good? Let me see yours if you don't have a dot. The flat bar. Yeah, for you, it's the flat side. See how one side's flat and one side's curved? Yeah, it's flat. Okay, everybody good? Good? All right. So this is the dot that I'm talking about. This is in the wrong configuration. I want this large diaphragm on the same side as the dot. So I would have to turn this whole thing around. Okay. Same thing with the double tube. We have a dot or a flat bar. Again, we would want to turn this whole thing over to open up. Now, the ear tips are the most important piece of this puzzle, and everybody puts these in wrong. I don't know why. I do not know why. Those of you whose earpieces are slightly curved like this, take a look at your earpieces. Are they already curved? Good, good. Let me see yours. Okay. Yours are good. There we go. Yours are good. Good. I'm going to turn yours. There you go. Let's turn it just a little bit more. There we go. Yours are good. Yep, yours are good. Yours are good. Yeah. Something like that. There you go. Okay, so your earpieces, for those of you playing along at home, should not be straight. See how those are straight? This is not how we want our earpieces. Our earpieces, if you hold down here at the chin strap, you can turn your earpieces a little bit. You want them to be more in this configuration. Okay, they need to have a little bit of a curve to them. So, question, when taking blood pressures, do we have to follow the care plan? What do you guys think?
Yes.
Yes, we follow the care plan for everything. Do we get to use our own BP cuff and stethoscope on the exam, or do we use what they're provided? In Florida or for Prometric, is this a tested skill? No, so we will not be doing this skill for testing. And Anthea asked, you have to wash your hands each time you do a skill. You'll want to go back and rewind this lesson because I did talk about that earlier. We're going to wash our hands at the beginning and the end of the first skill and simulate from there on. Okay, let's get back to blood pressure here. All right, so the earpieces are, some are already curved, like some of you, some have to be curved. We've already been around the room and done that. But the earpieces, when they go in, there is a right and wrong way to put these in your ears. There's a right and wrong way. So your earpieces, do you see this? See how they go in like this? Okay. Your earpieces should face your patient. So turn your whole thing around. There you go. There you go. Remember I said you're not going to hear earlier for a couple of reasons? That's why, because you had them in backwards. So did you. Yep. So I want you to turn your whole stethoscope around. Very good. You're good. Good. Okay. Put these, turn your whole stethoscope around. There you go. Put these in your ears. Okay. So they face forward. Put them in your ears. And tap your diaphragm. You should hear. You guys hear that? Take your stethoscope out, flip it all the way around, put it back in, and then tap your diaphragm again. Put it, do it one more time the right way. Got it? The way you put these in is going to determine what you hear. If you don't have the stethoscope in the right place, you're not going to hear the blood pressure. If you don't have the earpieces in your ears the right way, you're not going to hear the blood pressure. So these two things are super important when it comes to taking a blood pressure. And this is why most people fake the numbers. They lie because they don't hear anything, and rather than admit it and learn the right way, they make up numbers. Now, don't take my word for it. I own the retail store. We had a person come in recently. His wife, he was shopping for scrubs. His wife said, "Hey, don't you need a new one of those? Didn't you say yours broke?" She was pointing to a stethoscope. He says, "Yeah, I don't worry about it. If they're fat, I give them high blood pressure. If they're skinny, I give them low." These are the medical professionals out there, guys. Jacob was working. I went back and watched the video. I've got it on video. Jacob was working, and he doesn't feel comfortable confronting. If I'd been in there, I probably would have said something. But, this is all ethics and integrity. It's just ethics and integrity. And, unfortunately, it's not something that can be taught. You either have ethics and integrity or you don't. And if you don't, please don't go into healthcare.
Isn't that like illegal to isn't that basically like misdiagnosis?
Well, we don't diagnose.
Well, whatever he was.
So, yeah, I don't know what I'm assuming he's not a nurse. I would hope he's not a nurse. But remember, we don't have liability, our nurses do, right? So ultimately, it's their responsibility. They have to trust you. This is why I teach, guys, because I worked with a whole lot of CNAs that I couldn't trust. So I'm trying to make you the CNAs that I wanted when I was working. So the nurses that you work with will like you. Okay? Good? Make sense? All right. So when we put ear tips in the wrong way, it is the most common error. So what we're going to do is inflate the cuff to 160 to 180. We're going to deflate very slowly down to 0. We're going to listen for the first thump and the last thump. Remember, it's going to be quiet. We'll hear a thump. Wherever that thump is our top number. We'll hear more thumps, and then they'll start to die away. The last thump is your bottom number, and then it'll be quiet again. Good? Everybody understand this? You think?
All right. So look on page 57. We have this great box here. I want you to be able to answer. I want you to read the lesson on page 56 and 57 and be able to answer all of this before you come back into class on Wednesday. Okay? You can practice taking blood pressure on others. That's okay. But unless you know this, actually doing it isn't going to make any sense. So make sure you read the lesson on 56 and 57 and be able to answer this before you practice on real people. And we will have a little bit of time in class on Monday, or I'm sorry, on Wednesday to practice as well. So bring your blood pressure cuffs and stethoscopes to class with you. Unfortunately, we're just a little bit behind on time. So you're not going to be able to practice this in class today. We'll do it on Wednesday. So let me get you your review sheets. Please remember you have one chapter of work to do for homework, chapter 4. Chapter 4 is on body systems. It's unnecessarily complex. So when you're doing this reading, I want you to know the changes of aging. That's what I want you to focus on. What's a normal aging change? Just like we learned about the changes of skin today, I want you to pay attention to the changes of aging. And let me get your review sheets. Can you take one and pass them down? You're welcome.
Thank you.
Yeah, so let me show you how to wrap them up. Hold on. If you can take one and pass them. So to wrap up your blood pressure cuffs, you take your cuff, so your gauge is facing you, fold it like this, bring your bulb, and then wrap it up like that. And then this tubing just does that. Okay, so let me do that again. I'm face you this time. So I have this cuff. Okay, cuff. I folded this end in, folded this end behind.
As of December 21st, essential businesses, non-essential businesses, public transport, restaurants, and tourist attractions are open in Florida. Social gatherings are allowed with fewer than 50 people.
I have no idea. Fire TV. Okay, so I have this now kind of compacted with my gauge facing me. Like it would be like this. I'm just doing this for you. Take your bulb, put it right beside your gauge. Wrap this flap around both. And then these tubings that are hanging down, you just flip them back up. And now the whole thing goes in your bag. And then if you have a stethoscope, this just kind of gets wrapped up any way you can. Just however you can and shove it in your bag. Do not leave these in your car because they're made out of rubber. And the rubber over in the car, it's going to expand in the heat. And then when you take it inside, it contracts. And that's how it wears out the rubber balloon in between. If you want it to last, don't leave it in your car. Okay? All right. All right. Have a great evening. I will see you in class on Wednesday.
Thank you.
You're welcome. All right. Bye, YouTube world. See you tomorrow on the game show.